Good evening, ma'am.
Hi, how is
How are you?
everyone?
Fine.
Hi, Dr. Indu.
Hello, I want to maximize this. Right. Mm. Come on. Technical वाला वो एक जैसे mention.
Good evening, ma'am. Good evening, sir.
Good evening, good evening.
Hello, good evening, sir.
Am I talking to Dr. Brijbala Tiwari?
Hello, Dr. Indu, ma'am. Good
Hello.
evening.
Hi, Dr. Archana Baser here.
Hello, Dr. Archana.
How are you, Dr. Indu?
I'm fine, I'm good. I keep
So,
on receiving your posts. Thank you for all the posts that you keep on sending. That's wonderful connecting to you
thank-
now in person.
that's nice. Actually, this has become a way forward. I think there'll be more and more, online
Of course.
platforms where we will be better way to connecting with our colleagues.
Yeah,
You don't have to spend travel time. You can connect, update yourself.
that's right.
I think in the modern ways, times, that is the way we are looking at. Maybe once or twice a year, just a conference,
Yeah.
attend 4 or 5 conference, that's all, and rest, update yourself by this medium.
You're so right. Actually, what I've realized, like for doctors and lawyers, you have to be based at one place for your work. So it suits us, all of us, doing webinars and being updated. And as you rightly said, once or twice you're going to these conferences.
Yeah,
It works very well. And then whatever you're doing in the middle of it, you can just attend to your webinars as well.
exactly,
That
exactly.
works very well.
It
Hello,
saves a
Dr.
lot of
Nikhil,
traveling
Nihar.
time.
Yes?
It saves a lot of traveling time, and we are
Yeah. You're right.
sharing knowledge.
And basically, you connect with everybody online, and then maybe 5 conferences in a year, choose, and then you can meet different regions people in that. So, I mean, that's what I realized. What you said, Dr. Indu, is so true that doctors and lawyers, they cannot work outside their offices. So during full campaign of presidency, I've been working. Even today morning, I did my LACS because patients don't leave you. 9 months pregnancy,
Exactly.
you cannot, 9 months, I cannot be doing campaigning and leaving my work. Only on weekends I traveled. Rest of the time I was here. So that's how I did. But I had a
Yes.
great team and support
Hello,
of
good evening,
everybody.
Rajat, sir. Good
Rajat
evening,
Good
is a
evening,
great
sir.
friend. Hi Rajat,
Dr.
how are
Archana. Good
you?
evening, Dr. Prajwala and others. Good evening, Dr. Archana. Good evening.
Good evening, Dr. Rajat. Good to see. This is Brajbala's brainchild. Combine all. Previously, we were doing 2 states, then 3 states. Now she has said, Madam, now we are coming to the peak of our, webinars and collaboration. Let's do 4 states. So that's so wonderful. We
I
have
think it's
like
a very good idea, Dr.
Northeast.
Archana. It's a very good idea because so many, every state doing now, and then every topic, every association doing webinars. It's like it's a wonderful idea. 4 states getting together and then working together. I really like this idea. Really,
Uh,
I don't know whose
Thank you.
brainchild it is, but congratulations to the person. I think you, right?
Yeah, we were sitting in a car actually, and we were traveling and we were making, roadmap. And then,
Mhm.
yeah, both of us had an idea, but Brijbala immediately jumped and picked it up.
Mhm.
That, ma'am, let's do it. And in the car only, she made the program till 31st of July. While
Okay,
traveling from Nagpur to
great.
Amravati, 5 from 1st July to 31st July, every Friday, she made 5.
Indu,
That's
madam, you
right.
reminded me one of my friend from Jammu, Kashmir. She was my batchmate in MBBS, Dr. Aarti Kol. She
Dr.
was Aarti Kol.
Aarti Kaur, which batch are you from?
I am from 84 batch, ma'am, from MGM Indore.
Aarti Kaur 84. Okay, I can't place, maybe by face I can
Yeah,
take. Was
but
she from Srinagar or from
unfortunately,
Jammu Medical
she was
College?
from Jammu, ma'am.
Jammu. Okay, maybe my face I can, because yeah, that time I was in Srinagar actually.
Okay, ma'am.
That time I was in Srinagar. Mm.
We have Dr. Madhumita ma'am. Good evening, Dr.
Good
Madhumita.
evening.
So we are having,
Good
Everyone,
evening, everyone.
all states have come, Raj.
yes, madam. I think
Dr.
Aman
Amit.
and Dr. Gauri is there. Dr.
Nihar bhai also joined.
Yeah, Dr. Nihar is
Hi,
there.
Dr. Nihar. Yeah, I've seen Dr.
Hi,
Nihar.
good evening.
Hi, Dr. Boy. How
Good
are
evening,
you?
ma'am. All fine, ma'am.
All fine?
Thank
In
you.
between the work,
Yes, ma'am.
connecting.
Yeah, in between.
Dr.
Yeah, it's
Sunil sir
nice,
is there.
you can make one or two patient wait for 15 minutes and then you can come
Yeah.
in between. I think most of you work till 9 p.m., right?
Good evening, Dr. Sunil.
Good evening, Dr. Indu. Good evening, everybody. A warm greeting from Jammu to all of you.
Hi.
Hi.
So I shall be calling Dr. Amit Patki sir
Yeah,
once.
and then we start because everyone is here.
Yeah, ma'am. I am calling sir. Ankita, are you ready with everything?
Yes, ma'am.
I think I'm not seeing Dr. Amandi.
Yeah.
And Dr. Gauri is there.
Yes, ma'am. She is from.
Hi, Dr. Gauri. Good evening. And Dr. Milind. So in a minute we will start. Ankita, Mr. Pradeep, you are there now. You are here.
Yes, ma'am.
Yeah. Okay. So just give me 1 minute. I'm calling Dr. Amit sir. Phone was busy. So shall we start, ma'am? I think sir will join.
Yeah,
phone
I think let's start. He will
So
join
we
and
will
we'll
start.
introduce him when he joins so that
Yeah.
everyone's time in between when they are in
Yes,
the
madam.
video.
Yes.
Yeah, so let's Ankita start.
Hi. Good
Hi,
evening.
Amit.
I'm joined. I'm joined.
I knew Amit will come
I
on
was
time.
Amit, good evening.
Yeah,
So
I was
Amit, just wanted to tell you this idea of 4 state is so nice. It's working so well that we connect with our colleagues on
Yes.
this platform
Which
from
are the
different
4 states?
states.
Can you tell me again? It is
Today the
MP.
4 states are Goa, Jammu
Yeah.
and Kashmir,
Yeah.
and Orissa and Madhya Pradesh.
Wonderful. Perfect. All right.
Yes,
I'm
so
set.
let's start. Let's start.
I'm
Yes.
set.
We go live now.
Yes.
Yes.
We are live.
Okay. Good evening, everyone. A very warm welcome to all the respected dignitaries, faculty members, and all the delegates. Thank you all for joining today's webinar. As we begin the proceedings, I request our team to play a lamp lighting video to offer our prayers to Almighty.
शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् सन्ध्यादीप नमोऽस्तु ते ॐ दीप ब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीप ब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश मतिं स्वच्छां हि मे सदा.
Thank you. As we move ahead, I would now like to invite and introduce Dr. Brajwala Tiwari, ma'am. May I have the CV, please? We welcome Dr. Brajwala Tiwari, ma'am. She is consultant gynecologist and infertility specialist at Life Care Hospital, Indore, Santiti Infertility and Test Tube Baby Center, Indore. She has many awards and achievements to her credit. We welcome you, ma'am.
Thank you, Dr. Ankita, and very good evening, all the faculties and all the delegates who had joined this webinar today. And this idea of bringing 4 states together on this month of IVF, World IVF Day, last week only, on last Friday only, we had completed 48 years of first IVF baby, and the credit to that patient and the doctor who bring this to world, this World IVF Day. We were doing webinars with 2 states, 3 states, and now today with 4 states. And I'm very, very thankful to my chair, MP chapter ISAR, Dr. Archana Basir, when we thought of bringing 4 states from different corners of India, because most of the time we are doing with our own chapter, but there are some different patient pattern, different practice pattern in different areas. Like in some areas there is more of PCOS patient, in some areas there is more of advanced age patient, they are having low ovarian reserve, in some area tuberculosis is more common. So that's why it's a great to share idea with all of us. And I'm thankful to our guest, chief guest, none other than past President ISAR, Dr. Amit Patki sir, and the chapter chair and secretaries of GOA, Dr. Milind sir, Dr. Gauri, and from Jammu Kashmir, Dr. Amandeep, and Dr. Anil Mehta sir, from Odisha, Dr. Rajat sir, and Dr. Madhulita madam, for making this possible. So without wasting much of time, we are going to start with our academic session, and for that I'm inviting none other than MP chapter chair Dr. Archana Basir ma'am, and madam is well known figure in Foxy, and she had been associated with many positions, not only Foxy, ISAR, SAFOG, AOFOG, and I'm working with ma'am since last 2-3 decades, and she's so meticulous and so inclusive to take everyone with her, and always taking care of all the staff, all the colleagues. So I welcome you, Dr. Base ma'am, to invite our guest for today and to welcome Dr. Amit Patki sir. Over to you, ma'am.
Thank you, Brajbala, for kind introduction. Thank you very much. Let me welcome all of you on this platform of 4 State, and I'm really happy to see my dear friend Dr. Amit Patki, who has joined us as a chief guest. Amit, I known from more than 3 decades, and Amit has been a person of so much academics, and the person, he's a really good true friend, a very good human being, and once he decide to do something, he does it, and he has his own special ways of doing the things. And I'm really glad that we have all the 4 states chairpersons and secretaries with us: Dr. Anil Mehta, Dr. Rajat, Dr. Milin, Dr. Amandeep, Madhumita, Dr. Gauri, and we have Dr. Kaul also, and all the speakers and chairpersons and all the panelists and moderators. A warm welcome to 4 State Chapters webinar. I think what Brajbala has said, that because we have a different patient profiles, so it's good to know the challenges we face in our own practices. So with this, let me invite Dr. Amit Patki on the podium. Can I have his CV? I would like to read a little bit of his CV. He's honorary associate professor, KJ Somaiya Medical College. He had been president of MOGS, fellow representative of Royal College of Obstetrician and Gynecologist. He had been chairperson of AICC RCOG West Zone. He is member governing council ICOG, member managing committee ISAR, and he has organized AICOG 2013 Mumbai. He has been, like so modest. He has not put many things on his CV. I know he has so many patents to his name, and he has lots of publications to his credit. So over to you, Amit. You've been the chairperson of president of ISAR. You know how it is to connect the four states and to learn from each other. So please give your inputs, your advice, and your blessing on this webinar.
Thank you very much, Dr. Archana, for your kind introduction, and thank you to the organizers of this webinar for having me as your chief guest. Good evening, everybody, and it's a pleasure being with all of you. I'm so happy that people are now collaborating and coordinating with each other, because I feel the efforts get divided, but the returns get far multiplied when you collaborate and join hands. So I'm happy that the chapters of Goa, MP, Jammu, Kashmir, and Orissa have joined hands to singularly come on one platform. And I congratulate you all sincerely on this unique collaboration. As president of ISAR, having 29 chapters, that was my singular aim, that people join hands and not have multiple functions, because it becomes logistically difficult even for the organizers, the educational partners, and mainly for delegates to join frequently. So hearty congratulations, Archana. I'm sure this is your brilliant idea, because I've seen you working very closely in West Zone RCOG and in MP, and I've seen your organization skills even when you organized the last AICOG in very troubled times in Indore a few years back. I wish you the very best in all your future endeavors, and I'm sure you will come up with brilliant success in whatever you want to do. I take this opportunity to thank all the faculty who are there in the scientific program, and I'm as eagerly waiting to listen to all of you. So best wishes, and best wishes to you, Archana, and best wishes to this webinar. Thank you.
Thank you, Amit. Thank you for kind words. Thank you for sparing your time. And I really need wishes. And I'm really moving forward in Foxy with wishes and support from friends like you. So thank you very much. And I think we move on to
Yes,
our academic session. Before we move on to academic session, I think Brajbala always like that all the chapters, president and secretary, should speak even one or two line about the webinar. So it will be nice to invite Dr. Anil Mehta and Dr. Rajat Ray for their inputs, and Dr. Milind if he's here, about this webinar.
So, Ankita, will you share CVs of...
yes. May I have the CVs? We welcome.
Thank you very much for inviting me. In fact, it is a pleasure to be a part of almost a pan-India webinar inclusive of Hello, can you hear me?
Yes,
Yes,
Dr.
yes.
Anil, we can hear you.
Yes, it is a pleasure to be in a webinar which is almost a pan-India webinar inclusive of 4 states, and the concept is great because, as you were saying that, as Dr. Indu was saying, in fact, that it is very difficult for doctors and lawyers to move on for various places all the times to get educated and interact with people. Yes, now life has taken a, after COVID, life has become such that it's a near normal to be hybrid. Hybrid in the sense that you can always attend webinars, be at your own place and attend. And then, like you can visit conferences of your choice. So I wish all the luck to participants, and I think this is going to be a very amazingly enlightening webinar in various aspects of infertility. Thank you.
Thank you, sir.
Thank you,
Thank
sir.
you for your inputs, and thanks for joining for this webinar, Jammu Kashmir chapter. Thank you so much, sir. Can we have inputs from Dr. Rajat Ray, sir, from Odisha?
Congratulations, Dr. Hello.
Welcome, Rajat.
Yeah. Congratulations, Dr. Archana, for arranging such a webinar with 4 states of ISAR. It is a novel idea, and I must appreciate my presence of my friend Dr. Amit Patke here as the chief guest, and all the chairpersons and secretaries of all the states are present, and all the faculties. I must congratulate them, and I must say wish you all the best for your all future elections. And we want to
Thank
see
you so
you
much,
winner
sir.
of the elections. Thank you.
Thank you so much,
Thank
sir.
you, sir.
Do we have Dr. Milin, sir, from Goa? Are you Dr. Gauri? Anyone? Dr. Milin, sir, is there? I think.
Don't
So
think
can
Dr.
we
Hello?
invite
Yeah,
Dr.
yeah,
Gauri?
hi.
Can you hear me?
Yes,
Yes,
sir, we
Milind.
can hear
Yeah.
you. So
Okay.
welcome, Dr. Milin, for this 4-state webinar.
We met at Delhi, Milind. Yeah.
Yes, madam. Yes, I know. Tomorrow is a great day.
Yes, it is. You all are there, no, to support
Yes,
me. So
definitely.
I'm
Definitely.
happy. Yeah.
Definitely.
So, sir, your inputs for this.
It's a great to achieve 4 states is first of all a great achievement, and to have such nice committee members and panelists is also a feather in the cap. So I'm looking forward to this webinar. Yeah.
Thank you
you,
so
Milind.
much. Thank you, sir. We have with us Dr. Madhumita, Dr. Gauri, and Dr. Amandi, probably.
Yes,
So-
this is Gauri here.
Yeah, please
Yeah.
give your inputs also on this
Yes,
association.
yes, madam. Good evening to all. Wonderful joining here for this 4 states webinar. Right from Jammu Kashmir to Odisha to Madhya Pradesh and Goa. What a wide geography you all have covered. Hats off to you all. Amazing. And big names on the panel. I'm definitely here to learn more from you all. Thank you so much for having us with you. Thank you.
Thank you, Dr. Gauri. I think Dr. Madhumita is there.
Yes, she's there. I can see Madhumita.
Dr. Madhumita?
Yes.
Yeah, from Odisha, Secretary Odisha. Please, you need to
Yeah,
unmute.
mute, ma'am.
Dr. Madhumita, you need to unmute.
Hello, can you hear me
Yes,
now?
yes. Yes.
Good evening, everybody. It's indeed a pleasure to join you all in this session. And I think it's a very good idea. You know, it avoids travel, avoids losing work and all that. So I'm very happy to be here. And I wish you all the best for such endeavors in the future. Thank you.
Thank you so much. So I think I'm not seeing Dr. Amandeep here. So we'll take her inputs because she's a moderator also in panel. Dr. Amandeep, are you here?
She's doing a LSES.
Okay, so we will, she's going to moderate a panel. So we are going to listen from her. So thank you everyone for joining for this 4-state webinar. And now we shall be starting our academic session. So for that, over to you, Dr. Ankita. Will you please invite chairpersons for first talk?
Yes, I would like to invite our respected chairpersons. May I have the CV? We welcome Dr. Sunil K. Chaudhary, sir. He is patron and founder chairperson of ISAR Jammu and Kashmir chapter. He is ex-graded specialist in Jammu and Kashmir Health Services and Medical College, Jammu. We welcome you, sir. Now I would
Thank
like
you.
to invite Dr. Rajat Ray, sir. He is professor and head at High Tech Medical College. Raurkela, President, Indian Federation of Ultrasound in Medicine and Biology. We welcome you, sir. I now request Dr. Rajatri sir to kindly invite our first speaker, Dr. Archana Basir ma'am, for the first lecture.
So it is my proud privilege to welcome Dr. Archana Basir for our first talk. She has already been introduced by Dr. Prajwala, and again I wish her best of luck for the forthcoming election from tomorrow. I want to see you as winner. Without wasting much time, I will request Dr. Archana Basir to start the proceedings.
Thank you, Rajat. Your wishes means a lot to me. And may I be allowed to share my screen? So I think my screen is visible. So once
Yes,
again,
madam.
welcome to all of you. And if you have not known, Rajat and me also know each other for long. Actually, in Imaging Science Committee, I am just following the Rajat. I was used to take advices from him, and he would guide me. And he is the one of the person who said, "No, you are the person who should go in Imaging Science." And it's good that he's chairing the session. He's been great person in imaging science. So my topic is evaluation of infertility by ultrasound. As we know that we cannot really survive without ultrasound in modern days. And today's generation is with one hand ultrasonography, I mean transvaginal probe, and one hand they have their endoscopes in one hand. So this has become a norm. And it is very, very important that we all of us become sonogynecologist or sono obstetrician. We should know how to do sonography, and sonography is in a modality which really can be learned, and you can do the workshops, you can attend it in the focused centers. And but it has become kind of a something you cannot really complete your diagnosis or giving your treatment, especially in the infertility, is it is a must. So this is the ultrasonographic anatomy. This is a sagittal section of the uterus. You see the myometrium, you see endometrium, and you see serosa. And these are the layers of the myometrium and endometrium here. I always put in my talks this picture because what I always say that myometrium is something which is so very important. You cannot assess this except the sonography. You can see serosa and other structures, fibroids by laparoscopy. You can see the uterine cavity by hysteroscopy, but for seeing the myometrium, you need is a good ultrasonography. So it is, and we know that the role of myometrium is great because the blood supply to the endometrium goes via myometrium, and assessing myometrium for adenomyosis and fibroids is very, very important. And these are the different layers of the myometrium: inner junctional zone, middle, and the outer zone. And this is again a normal anatomy. In infertility, we are interested that there has to be a normal endomyojunction. Of recently, I have learned that if there is a thick endomyojunction, not only the absent endomyojunction, thick endomyojunction is again a case of a problem. These are the women who are likely to have more miscarriages, infertility, IUGR in preterm. So you know how ultrasonography is evolving. So many studies are going on, finer points that EMJ absent, EMJ thick is and very, very important. And this is a picture of adenomyosis where you see that endomyojunction is not visible, and what you see is appearance of adenomyosis, invention blind appearance, or salt and pepper appearance. And look at the shape of the uterus; it has become round and globular. In olden days, they were used to label it as a multiparous uterus or a bigger uterus, but now you label it either adenomyosis, fibroids, or you are labeling it with the MUSA guidelines, or with FIGO classification of the fibroid. So it is very, very important. And this is again here is a normal endomyojunction. Now, why do we do sonography in infertility? Number one, looking at the shape, size of the uterus, myometrium, and for the assessment of the follicle. I'm not going to take you through the full follicle study, just going to touch upon few things. assessment of the follicles to know if the follicle is mature and going to yield a good quality fertilizable ovum, and to limit the incidence of multiple pregnancy, one of the big complications of ovulation induction, and whether endometrium is ready to accept an embryo. This is why we do assessment. Initial days when transvaginal sonography was not available, we were used to do transabdominal sonography to do the follicles. In that era when I got trained, there was not much transvaginal ultrasonography. So we have learned that way, but now we see a huge difference in our follicle study, and especially when you put color. And this is a typical picture of dialogue between hormones and vessels. If you know and if you learn your ultrasonography well, I tell you, you need not do your hormonal estimation. You can see the RI, PI, and you know whether the progesterone has come into the circulation, when the LH surge is going to happen. So that way you save the time of the patient also, and you save a little bit, it becomes economical rather than subjecting for the endocrine estimation every time. Look here, the follicle which is surrounded more than 3/4 by the blood supply, you know this is a very good follicle, which if is going to yield ovum which is going to be fertilizable. So it is very important that we, with the follicle study, we do put color around and see. So that has become a norm these days. And like, how many scans in one cycle one should do? Do 4 minimum scans. That's what we have been doing. Do a baseline scan, day 3 scan, do enteral follicle count, and always do ovarian volume as well. Day 7 or 8 scan, depending on what is your protocol, a pre-ovulatory scan. And most of the centers are not doing the luteal phase scan. They just do the pre-ovulatory scan, give a trigger, and well, you can have timed intercourse, or even if you are doing IUI, but do a luteal phase scan. That's what I'm going to bring this point here, because luteal phase scan is very important for us to know that there is enough progesterone in the circulation. There was a follicle has come out, the corpus luteum, corpus luteum is there, and then this corpus luteum, whether there is a luteinization of unruptured follicle, or there is a hemorrhagic cyst, and or whether the follicle had actually come out, and and do the RIPI also. So these are the 4 scans which we do. So this is a day 3 scan where we are doing a day 3 scan where we are doing endometrial thickness, ovarian volume, and we are measuring the follicle. Then day 9, day 14, and day 19, this is a good luteinized endometrium. You see the blood supply as per Appelbaum classification, and you see here is the corpus luteum. You know what we have done in our clinic? We have kept this picture under, in our clinic where we are scanning the patient or where we are counseling the patient. It is important so that you know what happens if sometime patient does not get ovulation, or if their follicles are not growing, we can tell them that, look, this is the basic, this is the norm, and since ours is not growing, we need to add on gonadotrophins, or we need to cancel the cycle or do other cycles. So pictorial, picture if you show, it tells a lot, and patient gets convinced, and that's much better. So this is how we do our 4 scans, and this is how you do measure your enteral follicle count. It is less than 5 are poor responders, 5 to 12 is a good responder, and more than 25 is hyper responder. Now, just brought one case to highlight the role of ultrasonography, and especially the ultrasonography by the gynecologist or by the infertility specialists themselves, or even if you have someone else doing ultrasonography in your setup, please request that detailed ultrasonography is needed. You need to see the adenexa well. Just do not only focus on endometrium and follicle size. I just had a couple who came to us with reports in OPD for second opinion. On and taking history, we found that the couple was young, only 30 years. They have no comorbidity, average BMI. She had a regular cycle, 28 days, lasting 3 to 5 days. They're trying to conceive since 1 year. Husband has been diagnosed with OATS, and patient had undergone 2 cycles of IUI, and she was diagnosed with left-sided tubal blockage and hydrosalpinx on HSG after IUI was being done. They came to me as they were advised an IVF and wanted an opinion prior to that. So what we did, I insisted that look, we assess our patient prior to advising any treatment. We took a history and found that she had progressive dysmenorrhea, scanty menses. She initially had pain on her left side and was diagnosed with some cyst for which she had taken treatment. She recently started having pain on her right side as well. We did a pelvic examination and found tenderness. So we decided that to do a TVS and ultrasound, and these were her findings. Look at this. So this was not hydrosalpinx. This was a kissing ovaries. This is a grade 4 endometriosis. So probably this was reported as hydrosalpinx. And look at the typical picture. There are no follicles seen. I think this is kind of something which should not be missed, because endometriosis is a progressive disease. If not treated on time, it can engulf ureter and other structures also, and maybe it destroys the ovary and there will be not normal ovarian tissue left. So this young patient had an AMH, quite low AMH, and look at her ovaries. So this is the ultrasonography. Like you see here, you can even, if you master, you can even see the ureter. Here you can see the ureter, which is seen, it is just a little narrowing here, and this is a endometriosis. No follicles are seen here, and even here you see that there is very little follicle seen. So you in modern days you cannot really see that a patient is allowed, the disease is allowed to progress or being missed. It is very important that it is diagnosed and it is handled, it is treated. Infertility treatment is important, but it is important that while we start on the treatment, before treatment, we make a complete diagnosis and offer the patient best treatment. So that is what is. And one more thing I want to tell everybody, that when you find a deep endometriosis, deep invasive endometriosis, please look at the kidney as well. We all can just put our probe on the abdomen, look at the kidney, because we had 1 or 2 cases where we had to do nephrectomy because ureter was completely blocked, hydroureter, and the kidney was completely damaged. So we had to do unilateral nephrectomy. Since then, I'm always telling everyone that always in a case of endometriosis, always put your probe on abdomen and look at the kidney as well. So that is very important. And we are living in an era where endometriosis is going to increase, and endometriosis is increasing. And we really need to know how to diagnose it, how to treat it, and how to prevent the complications associated with endometriosis. So just I'm going to leave you with this question. Is it okay to miss an obvious diagnosis of endometriosis in this age of high resolution ultrasound and let the disease progress? How would you proceed further? And should ultrasound be a part of initial assessment of every patient with infertility, and a detailed and a very diligent assessment of pelvis by ultrasound? It is easily available. Patients are ready to accept ultrasonography. This investigation, patients never, I mean, very rarely say, no, we don't want an ultrasound, because it is non-invasive, available, and it is not as expensive as MRI and even the biochemistry. So we can offer, but we cannot be just do a simple without going into the details. So thank you very much for patience listening, and I request you all that to vote for me. Tomorrow is the day. Vote and support me, and please do advocacy for me for Foxy President election tomorrow. I'm with you, I'm for you, and I'm by your side always. And believe me, I'm one of you practicing obstetric, gynec, and infertility. I'm grateful for your trust over the years. With your support, I'm advancing in Foxy together. So thank you very much for patience listening.
Thank you,
ma'am.
Dr. Archana, for a small, crispy talk on ultrasound and infertility. You started right, starting from day 3 of periods, when we see a antral follicular count, till the luteal phase. Because most of the people, what they stop is they see a follicle, they do give a trigger and forget it. We should see whether the follicle has ruptured or not. There's another problem. We do not. We sometimes we see unruptured follicles. So that's another And then the progesterone support, when to give and when not to give. Secondly, I just would like to ask you your experiences about endometriosis fertility index by ultrasound. Any comments?
Yeah, we do. I think we have a very good unit who is dedicatedly doing endometriosis scan. Dr. Anshu Basir, she's my daughter and a gynecologist, and has expertise of doing endometriosis scan. She got trained with Dr. Sonal Panchal in other centers. She's doing her laparoscopy also, but I think we are doing endometriosis index also she's doing, and adenomyosis also she's putting all the time. When the report comes to me, with the Musa guidelines and with the FIGO, all the fibroids mapping is being done. So I think it is very important that we do. But what happens, Dr. Sunil, in a busy infertility clinic, sometimes people are not putting the indexes. But what I say that always look at the Adinexa and look with a very careful reporting, because many of them may not be doing sonography themselves. They may be sending it to their colleagues, but whenever even you are sending it to your colleagues, request that yes, I need these many details. If you are reporting endometriosis, I'm not ready to take the report just as an endometriosis. Please tell me the grade of endometriosis, deep invasive endometriosis, whether ureter is involved or not. I'm sure all ultrasonologists can pick up if the ureter is involved, if they are doing a good endometriosis scan. I think there should be centers. Maybe each one of us should identify 3 4 of sonologists of our own city who are especially doing that, like in how it was done in UK when I was there, like an early pregnancy scan clinic. Different kinds of clinics are there, so one person is doing all endometriosis related scans. So more the number of cases they do, there is a skill enhancement and there's a better diagnosis. So I think those kind of units with endometriosis rising, we might have to come up with such things in our cities, or maybe amongst the infertility specialists who are practicing infertility. They can all identify that this person is doing good endometriosis scan. Maybe just ask him or refer it to him, and maybe you can have a, like how we are doing 4-state webinar, you can have cross speciality webinars and learning from each other and giving your inputs on the cases. What is the biggest thing missing in our practice is the follow up, because whatever findings are there, suppose if our sonologist has reported something, it's good that we give them follow up. So then that's how it improves each one. So I think that kind of practice we really need to start amongst ourselves, also connecting different specialty.
Wishing you all the best for your elections. And one thing I would finish off with is that every person who's coming, every gynecologist who's coming into infertility should take a short course of ultrasonography, transvaginal ultrasonography before jumping into infertility.
That's great, Dr. Sunil. I'm really so glad that we are thinking, alike. That we were the people who started this webinar culture, because I was vice president when COVID was there, 2020, and Dr. Alpesh Gandhi, our president, came up with a brilliant idea of webinar. And then me, my friend Dr. Meenu and Dr. Anita, we started online courses of ultrasonography, and we trained 1,000 gynecologists on ultrasonography sitting at home for 12 weeks course with exams. So I think I have this in pipeline. Like, let me see if the things come in, yes, I would like to restart this again and make everybody, learn ultrasonography. Thank you so much.
Thank you. Thank you. Thank you.
Thank you, Dr. Archana, for a nice presentation. Thank you.
Thank you, Rajat.
Thank
now-
you, Dr. Rajat sir, Dr. Sunil sir, for chairing this session. And it's my humble request, kindly put in support Dr. Archana Base ma'am. I think she is very right candidate for Foxy president. So can we move forward to our next
Yes.
session?
Thank you, Dr. Braj.
I would like to invite our chairpersons for next session. May I have the CV, please? Dr. Madhumita Mohanty, ma'am. We welcome you, ma'am. She is a consultant sonologist and laparoscopist with special interest in ultrasound and infertility. We welcome you, ma'am. Now I would like to welcome Dr. Indra Kaul, ma'am. She is ex-head and professor, Department of Obstetric and Gynecologist, Government Medical College, Jammu. She is ex-member governing body, AIMS Patna, ex-secretary, Indian Society of Assisted Reproduction, Jammu and Kashmir. We welcome you, ma'am.
Thank you. Thank you.
I would like to introduce and invite, request Dr. Madhumita ma'am to invite Dr. Milind Kolvalkar sir for the next talk.
Good evening, everybody. Hello, Dr. Milind. It will indeed be very nice to have you here and your expert opinion on the topic. The dais is yours. Kindly start your talk.
Okay, so
Hello.
one sec. Can you hear me?
Yeah,
We can hear you, sir.
Yes, sir.
Okay, can you hear me?
No, we can't hear you. We cannot hear you.
Can you hear me?
Yes,
Yeah,
sir,
now
we
we can
can
hear you.
hear
Yeah.
you.
Okay,
we can't
okay.
see your
Let me
slide.
share. Let me share my presentation. Can you see my presentation now?
No,
We
sir.
can't see your presentation.
Now, can you see my presentation?
Yes, it is.
Okay, so the one question which runs under everything that I'm about to show you is, when a good embryo fails to implant, was it the embryo or was it the endometrium we handed it to? We have spent years optimizing the first, but we have often treated the second as a room that's...
Just a minute, Dr. Milind. We can just see your name, nothing else, right? You'll have to move on.
You
we
can't
can
see
just
my
see your name.
slides?
Just your name and that's it. No slides. You'll have to share slides.
Teju?
Mr. Sudeep, can you help, sir? Any technical issue?
Have you opened the PPT first?
Yeah, PPT I've opened.
Yeah, you press the green button down, share is there.
He'll have to share that.
Yeah. Once you press the share button, you can see your PPT in that tray. Then you click on that and share.
Oh, share. No, I cannot. I think you can just take the next speaker. Let me just get through this.
So
you can try for a while. It will take us a second. We'll wait for you.
No.
You are getting the share button, the green color button down.
have you opened your presentation?
Just open and share it.
Yeah, the green button, once you press it, you can see your slide in that. Just select that and share button.
There is the Zoom.
Zoom is wait. Oh, there.
Where?
Wait.
Yeah, no?
Wait. No, but start your video.
You can start your presentation.
How to start this presentation?
Can you see it?
Either you
Just do
know
this share.
what.
Do the share.
There's something.
Can you see something now?
Not yet. Yeah, it's coming.
Yes.
Come?
Yes.
Yeah. Now it has come.
Perfect.
Yes.
You need to make it slideshow.
Yeah. Okay.
Yeah.
You can open your video also.
Okay. No, it's okay. Okay, so the question is, when a good embryo fails to implant, was it the embryo or the endometrium that we handed it to? We have spent years optimizing the first. We have often treated the second as a room that simply had to be tidy enough. Next slide. Okay, so what are the learning objectives? So 5 things by the end of this. First one is, choose between natural, modified natural, letrozole stimulated, and program preparations on evidence base rather than habit. Interpret the recent landmark trials, including where they disagree with each other. Individualize for conditions like adenomyosis instead of applying one protocol to everyone. Separate the interventions with evidence from the ones carried by myometrium. And leave an algorithm you can use tomorrow. So the biological premise starts with the biology, because everything downstreams from there. Implantation is the three things, but it's multiplied. First is embryo quality, second is endometrial receptivity, and the third is synchronization. Any one goes to zero and the product is zero. The endometrium is not waiting passively. It reads the embryo, cytokines, integrins, adhesion molecules, signals moving both directions. It's a biosensor, not a bed. The window is narrow. Immune tolerances have to be established. Decidualization has to be complete. Miss either and a euploid embryo can fail. So the psychological blueprint is estrogen builds progesterone receptors estrogen builds progesterone receptors, which are unregulated glands, developing blood flow using progesterone. Progesterone then transforms what estrogen has built, the stromal decidualization, secretory changes, signaling molecules like LIF and VGF. The window of implantation should not be presented as a fixed universal LH plus 7 to LH plus 9. It varies between women. There are 4 pathways, not 2. We have a patient who's regularly ovulating. So we can either use the natural cycle or the modified natural or the letrozole ovulation induction. If the woman is not ovulating, then we have the programmed HRT cycle. The special situations include adenomyosis, recurrent implantation failure, and thin endometrium. So what's the defining protocol debate on modern practice? So natural cycle has advantages like psychological corpus luteum, which gives the best safety signal, but the trade-off is heavy monitoring, requires regular ovulation. The modified natural has advantages of preserving the corpus luteum, HCG trigger, and simplifies timing. The trade-off still requires active follicle tracking. The programmed cycle has advantages of a full schedule, independent, and it's highly schedulable, essentially when ovulation is absent or unpredictable. The trade-off is a complete absence of corpus luteum and hence an obstetric lift. The COMPETE trial. The COMPETE trial 2025 had 902 regularly ovulatory women, single-center randomized control. Live birth approximately 54% with natural preparation versus 43% programmed. But it was not powered by rarer obstetrical complications like preeclampsia. So the convergent validation. A 2026 meta-analysis had 11 randomized trials, close to 10,000 women. Live birth around 41.5% versus 39.2%, favoring natural approaches with lower miscarriages. But the nuances were that the benefit appeared driven mainly by modified natural cycles rather than true natural cycle alone. So the count. So the preeclampsia hypothesis is because of the corpus luteum, there is progesterone, relaxium, VGF, renin-angiotensin factors, which causes lower incidence of preeclampsia in natural or natural modified cycles. Also, it has been seen that there is lower PAPA, which is an established marker of preeclampsia and placental insufficiency. So the clinical takeaway, a decision pathway in which patients which needs FET should be either ovulatory or not ovulatory. If it is ovulatory, And if the scheduling is flexible, go for natural cycle. Otherwise, modified natural is a better way. If the patient is not ovulatory, then programmed or HRT cycles. Special cases, if there is irregular ovulation like in PCO, then letrozole induced modified natural is the norm. So in a natural modified cycle, we start with letrozole, do a scan on day 10, check for E2 and LH levels. If the ultrasound and LH is present and the follicle is of 18 to 20 millimeters size, then either we can do embryo transfer on day 6 or give a trigger and do our embryo transfer on day 5. If it's a programmed cycle, then we wait for withdrawal bleed, start estrogen. As the urinary ultrasound thickens, if it reaches around more than 7 mm, then we start the progesterone and do the transfer on P+5 or P+6. So optimizing the programmed cycles when necessary. So standard build-up, as I said in the previous one, but the crucial caveat is it is beneficiary in patients who are less than 40, having primary infertility and PCO. In such patients, if you give a leupride agonist depot, then the results are much better. So what about progesterone? Does a low reading on the day of transfer or before the day of transfer cause a problem? In cycles on combined dihydrogesterone and vaginal progesterone, serum progesterone did not predict ongoing pregnancy, but the embryo grade did. What if it is less? Yes, network meta-analysis of more than 7,500 patients shows rescue luteal phase support brings outcomes close to baseline when the deficiency is genuine and the baseline is vaginal only. The luteal support in a natural cycle, corpus luteum is present, so we need not give luteal support. Whereas in a programmed cycle, critical evidence update has shown that intramuscular and vaginal progesterone give the same results. So this is a very special case where if there is an adenomyosis for a patient, if there is a small disease of less than 3 centimeters, or if there is diffuse adenomyosis of less than 10 centimeters, medical optimization first, guided by embryo transfer. If it's a large focal disease, consider laparoscopic cytoreduction before transfer. If it's diffuse and severe disease more than 10 centimeters, consider surgery or delay the transfer for extended suppression. In adenomyosis, the endometrial-myometrial junction matters the most. If it is disturbed, then the chances of pregnancy are reduced. What about clinical add-ons? Endometrial scratching, PRP, GCSF, stem cells have no proven role. ERA testing, there is benefit in small patients, but more RCTs are needed. ERA testing for true RIF, low certain possibility, but more dedicated RCTs. PRP for confirmed thin endometrium, selectively. Also, there are emerging evidences for vaginal pre and probiotic use in patients with RIF. The most important step in the embryo transfer is the transfer itself. So the guidelines say that ultrasound guidance has the grade A evidence, use of soft catheter, not hard or semi-rigid, central cavity placement more than 1 centimeter from the fundus, clear the cervical mucus before transfer, immediate catheter withdrawal upon expulsion, no prolonged bed rest. Where the field still disagrees in natural versus program for obstetric safety is the compete alone trial wasn't powered for it. It was a pooled cohort data. So RCTs are needed. Fixed serum progesterone levels cut off for rescue. Real absorption is still actionable. ERA in recurrent implantation failure. observationally supported, but still awaits more RCTs. So the master decision algorithm is: in ovulatory, no red flags, modified natural cycle first. Irregular ovulation wants better odds than HRT, letrozole ovulation induction. Anovulatory, donor, logistic driven, programmed cycles. Suspected adenomyosis, stage by size, and EMJ status. True RIF after excluding embryo uterine factors, consider ERA. PRP if the ET is thin. Every transfer, ultrasound guidance, soft catheter, more than 1 centimeter from the fundus. Thank you so much.
Thank you, Dr. Millen, for an excellent and comprehensive presentation on this endometrial preparation and frozen embryo transfer. You picked up very important and relevant points, and I'm sure most of us are going to be benefited by this. I may specifically refer to your few points, what you said, that the role of endometriosis, how endometriosis has the adenomyosis has impact on the endometrial transfer. Yes, it does. And you have beautifully, with your clinical knowledge, made us understand how the fetus is to be transferred. Then you talked about the defining factors for the natural, modified, and the hormonal, cycle. And then the three important things that are these embryo quality, the synchronization, and the embryo quality. And we all know the goal of endometrial preparation is to achieve synchrony between the endometrium and the developmental stage of the embryo to maximize implantation. So today's discussion reminded us that FET has become an integral part of an assisted reproductive technology. Yes, there's no doubt about that. And then the optimal endometrial preparation remains one of the key factors of the implantation. So despite remarkable these advances, there is no universal protocol actually suitable for every patient. So we have to actually tailor it for every patient. And the choice between, as you rightly and beautifully explained, between the natural and then the modified natural and then the hormone replaced cycles, and it should be individualized, and that's important, and that is the take-home message. And taking into account the patient's ovulatory status, as you rightly said, the age and other factors, the clinical profile, all these are important, and that depends upon, and that will definitely have impact on the outcome. Equally important is to realize that endometrial receptivity is about much more than the endometrial thickness alone. We have to keep in mind, as you said, the synchronization between the embryo and the endometrium. And then appropriate progesterone exposure, yes, that's also important. And the meticulous attention to timing is crucial for achieving the best reproductive outcomes. Otherwise, displaced window of implantation contributes to the recurrent implantation failures. And then the current recommendations from ISRI and ASRM also support the individualized choice of protocol for FETs based on the ovulatory status. So that means we cannot have one universal protocols for every person. We have to individualize for every patient. And I congratulate you, Dr. Millen, for your beautiful and excellent presentation. And I also congratulate the organizing team for arranging a very, very informative webinar. And I thank you for inviting me to chair this session. Thank you.
Thank you, madam.
Thank you. I request Dr. Madhumita ma'am to share her remarks.
That was indeed a very informative lecture. And I'm sure all of us realize that the endometrium is the vital organ in the entire reproductive process. Thank you very much, doctor. It was very informative. Thank you.
Thank you. Moving ahead, I would like to invite our chairperson for the third session, Dr. Rajwala Tiwari ma'am. May I have the CV, please?
Ankita,
Yes,
I'm already introduced.
Okay, ma'am. So I request you to kindly invite and introduce our speaker, Dr. Shakti Kumar Tripathi, sir.
So We are going towards the third talk for this today's webinar by none other than Dr. Shakti Tripathi. He is a Chief Reproductive Medicine Specialist from Bargar, Odisha, and he had so many fellowships to his credit, like Fellow in Reproductive Medicine from Kerala, Fellow in Minimal Invasive Surgery from Ahmedabad, Mumbai, Fellow in Male Infertility and Sexual Health, Fellow in International College of Robotic Surgeons, and Doctorate in Embryo Transfer. So, and he is involved in so many conferences and very active Foxian, very active ISAR member from Odisha. So, welcome Dr. Shakti Tripathi sir for your talk on hormonal assay during IVF cycle, because there are so many dilemmas when to do, what to do, what is the interpretation. So, over to you, Dr. Shakti sir, for your talk.
Yeah, thank you. Thank you, respected Chairperson, Brajala ma'am. And I particularly very much thankful to the organizer and the program director for this event, Dr. Archana Basir ma'am, and also our previous president, past president ISAR, and the chief guest for this session, Dr. Amit Patki sir. And let me share my slides. Yeah. So to start my session, hormonal evaluation in the IVF cycle, and it is visible to everyone, the slides?
Yes, you are visible, audible, slides
Yeah,
are visible.
thank you.
Perfect.
Thank you, ma'am. Thank you, ma'am. So to start with, there are lots of hormonal evaluation tests are there, and are we doing over testing and under interpretation is done? So this is one of the issue. Many a time, many conferences, this part is discussed, and yeah, let me see. Yeah. So I think infertility, the millions of couples are involved and they are suffering. And hormonal evaluation is the cornerstone for the infertility and IVF workshop, and everyone agree with that. But that there are lots of confusion, unnecessary cost, and the delayed in the management. Everything is associated with it. So today we'll discuss some real life cases, some scenarios, and also that some of the guidelines and the practical points that we'll implement in our day-to-day practice in IVF cycle. And we also explore not only just the test to order, but the important part, why, when, and how to interpret the hormonal test, that is more important. The hormonal evaluation, I always call as a double-edged sword, because every day in clinical practice, we encounter patients with all are normal parameters, but still there is infertility. There are still something, they are not successful in the IVF cycle. There are also mild hormonal abnormality leading to unnecessary interventions that are done. There are multiple investigation ordered by different clinicians without a clear clinical indication. And lastly, there are conflicting laboratory reports creating a diagnostic uncertainty. So there is lots of common pitfalls in the hormonal evaluation. Let's see first, are we like over investigating and under interpreting? I'm giving some examples like ordering AMH test in every infertile woman in IVF cycles also without indications, diagnosis of PCOS solely based on the elevated AMH, treating a single mildly elevated prolactin level, we are going for treating a prolactin of 35 or something like that, interpreting FSH without understanding the estradiol and menstrual cycle time, and sometimes assuming that low AMH equal to infertility. And lastly, they are ignoring the clinical history while more we are focusing toward the laboratory values. So everyone knows about this hypothalamic pituitary ovarian axis, starting from which is the cornerstone of this my talk, and how it is we are manipulating and we are creating this control ovarian hyperstimulation that we'll discuss here. So starting from the hypothalamus, there is a pulsatile GNAS release in the anterior pituitary, there is FSH and LH secretion, followed by all the follicular growth. And the target effect from the, from the follicular growth also for estrogen that affects the endometrium also. So in the clinical what is the clinical implication in IVF cycle? In GnRH agonist and antagonist, we normally go for stimulated protocol. What we normally manipulating this HPO axis by antagonist or agonist. So in agonist cycle, normally that a flare of protocol, a flare and followed by downregulation. And in antagonist, that directly with competitive blockage of the LS surge with a downregulation. So any hormonal test that we are advising in IVF workshop, it should be what is the essence and the snapshot of the axis in a single point of time. So this is one of the important slide, and basing upon this, how you are going for the stimulation protocol and how these hormones are responsible for to get a good number of M2, that I will tell you. In everyone knows that from there is a paracrine control and also a endocrine control. In paracrine control, that is from primordial follicle to secondary follicles that are mainly paracrine control, and from small internal follicle to dominant follicle, that is on the endocrine control. So accordingly, normally in secondary and primary recruitment of the primordial follicle is independent of the gonadotropin, and we know that the secondary recruitment phase of the folliculogenesis and selection is mainly modulated by exogenous hormone that we normally go in our control ovarian hyperstimulation protocols, and accordingly decide the dose that will tell in the nomograms also. So what is the physiological principle of this ovulation induction protocol basing upon this hormone? Normally we maintain the level of FSH above the threshold level for the longer period to enhance the exogenous gonadotropin administration.
All the dignitaries on the dais who have joined in spared their time for this master class, because ultrasound master class is.
Hello, is it audible and visible?
And I am being well supported in.
Yes, doctor, you're audible. There's disturbance.
Yeah,
The
that's
video
small
playing in
background
the
sound
background.
there. Yeah.
Yes,
Okay.
you're audible.
Thank you, ma'am. So what we are doing normally in control ovarian hyperstimulation, normally we are maintaining a level of FSH above the threshold level for a longer period. That enhance the exogenous gonadotropin, or that can be done by the exogenous gonadotropin or the endogenous, that normally in case of a non-IVF cycles. On an IVF cycle or IVF cycle, normally you administer the gonadotropin according to we increase the threshold. So if we differentiate between the FSH threshold and the FSH window, FSH threshold, the growth of internal follicle start from when the FSH level lies above the threshold level. And it depends upon the sensitivity of the follicle to the FSH, which in turn independent of the number of FSH receptor. But what is FSH window? It is duration of time the FSH level above the threshold. So that determines the number of follicles selected from the cohort of this recruited cohort. A longer the window remains open, the greater number of follicles are secreted. So this is a picture. You can clearly see that in control ovarian hyperstimulation, normally we increase the window so that more number of all the cohort of follicles are recruited, and the target is that to get a more number of eggs in a IVF cycle. So everyone knows about the two-cell, two-gonadotropin model. The importance is that the estradiol production needs both the gonadotropin from LH from the endogenous substrate and FSH for the aromatization. So serum E2 during the stimulation is indirect measures of the granular cell mass and aromatase activity. And if you see in PCOS also, excess LH drive assess the thicker androgen output that overwhelming the aromatase capability. So in hormonal assays before IVF, what matters? First one is the individualized stimulation. That is normally do by nomograms, and with experience we are going for different protocols. I'll show what is the protocols in the last slides also. And we have to also anticipate the risks. Which patient are risks of OHSS? That we can know by the high FSH, high your AMH level, or detect the confounders. What is the confounders? Like your thyroid function, like hyperprolactinemia, endogen excess. So this part also should be evaluated in hormonal evaluation to detect, to get a good number of follicles in IVF cycle. And along with the counseling is the most important part, basing upon what is the AMH level, if the poor ovarian reserve, if the PCOS, or is a normal responder. Accordingly, we have to counsel this group of patients so we can predict what is the outcome. So what is the hormonal test done in case of a IVF cycle? In day two of the cycle, you can, that is for the theoretical purpose, I am telling everything, but in practice, what I am doing, that I also tell you. So normally what you are doing from FSH, LH, estradiol, AMH, TSH, and prolactin level. in my practice, what I am doing mainly MH, TSH, and prolactin. Prolactin also in not all cases when there is some symptomatic patient or galactorrhea there in an ovulation for long duration. In such cases, I am going for prolactin. The basic two tests are what I am doing routinely, that is on AMH and TSH. So if you go for the individual test from follicle stimulating hormone, you know that at the normal level, it drives the recruitment of both of the enteral cohort in each cycle. An elevated basal level FSH that predicts the reduced societal and not the infertility per se. So what is LH? LH is the important hormone that normal range that is 2 to 10, and it's a mid-cycle surge triggers the final oocyte maturation in ovulation and supports the corpus luteum progesterone output in the luteal phase also. What is the clinical significance in IVF cycle? LH, elevated basal LH with the normal and low FSH, the classical PCOS signature, you know that. And if there is a very low LH, suggest of hypothalamic pituitary suppression, and when there is a premature LH rise during the stimulation risk for early luteinization and endometrial embryo and asynchrony, which Madam was discussing about in the previous during the previous speaker. So what is estradiol? E2, the normally 20 to 60, and what is the role? It is produced by the granulosa cell by aromatization of the thicker-derived androgens and derives the endometrial proliferation and mitigates the negative or positive feedback on the FSH and LH. So I always suggest to always pair the basal E2 with FSH because a functional ovarian cyst could be excluded on scan if the E2 is. For example, if you are going for a baseline scan, if there is, and along with you, you got some follicle like more than 30 mm, something like that, you got a follicle. So you have to see that it is a functional cyst or it is non-functional. How we can do that? Just go for a E2. If the E2 level is more than 50, you can see that this is a functional cyst. So accordingly, you have to plan your cycle. So AMH level also most important. Normal range, you know that it produced exclusively by the granulosa cell of the p-ental and small ental follicles. And most important thing, the advantage is not regulated by HQ axis. So it is stable across the menstrual cycle, and any day of the cycle you can evaluate the AMH level. And I always say that this is the best available predictor for the ovarian reserve to stimulate, and it guides the starting dose of gonadotropin that you can start in a IVF cycle. So AMH interpretation, you can see that high AMH, always there is a high reserve, there is OHS risk in that, and always prefer for the antagonist protocol. Non-responder, you can do the standard response, but then I will tell all the dose what you can do basing upon the AMH level in the future slides also. Then enteral follicular kind always correlate with the AMH, because if someone asks me what is the more important, AMH or AFC, I always tell that AFC is more important, because what I am seeing in my eyes by a transvaginal ultrasound, as Madam was spoken and the first speaker was there. So you can see what is the number of follicle with the eye. So you can correlate with the AMH in that cases, and in normal scan of the cycle day 2 to day 5 before dominant follicle emerge, and it count every 2 to 10 mm of follicle in the both ovaries and reported in some. So enteral follicular kind and coach, for the best practice, I will tell you, use AFC and AMH together. They measure the same follicular cohort from two angles, and there is a consequence of the increase in the confidence in the counseling part also. Progesterone part, the more important part I will tell you, that is secreted from the corpus luteum, that everyone knows from the ovulation and support the secretory transformation of the endometrium. And the mid-luteal progesterone on the day 20 and confirm the ovulation, and on the trigger the stimulation cycle, progesterone must stay low. That is a right man, there is a major implication may be there. There is a condition called premature progesterone rise, that is PPR, when the serum progesterone more than 1.5 on the day of SCG or GNRS trigger, it is the control ovarian hyperstimulation. So if you are planning for a phase cycle, definitely you see that if it is more than 1.5, definitely you have to cancel this, because now I am maximum my cycles are FAD cycles. So in that cases, when I am preparing my HRT and endometrial preparation, I am seeing this value when to start during that, when I am starting the progesterone. But in phase cycle, if we are going, it is more than 1.5, better to freeze all cycle. That will be more advantage for the patient. So endometrial embryo asynchrony that was discussed in the previous speaker also, and because the implantation window opens too early and has a close by the same time the embryo arrives. So this is a synchrony always matters. And if there is a premature progesterone rise, that definitely asynchrony will be there. Prolactin level, this is one of the hormone, that is a lot of confusion about that. But I am always tell you, we go for a prolactin evaluation when that is the patient is symptomatic, like some galactoria is there, some symptoms are there. And in some cases, you are advising also in some cases, like when the prolactin level more than 100, you are advising for MRE. But MRE should be advised when there is blurring of vision, headache, and some other symptoms are there. In that cases, you have to correlate clinically, then only you can advise for MRE for the macroprolactinoma. So it is secreted from the interpituitary lactotubes, physiologically elevated in pregnancy lactation. There are lots of conditions where the prolactin is elevated, and that is not pathological. Simply you are taking some PPI, proton pump inhibitor. In that cases also, that prolactin elevated. You are taking some stress. In that case also, prolactin weight loss protocol. So all of conditions are there. Many physiological cases where prolactin elevated. So in such cases, when there is symptomatic patient with a significant rise in the prolactin, then you can go for a treatment with cabergoline. Thyroid hormone, I am not going to details. I think it is one of the most sensitive screening tests in the thyroid function. And target level should be, for the infertility patient, it should be less than 2.5 before starting the stimulation. And that is one of the most important points you have to consider. You must evaluate the thyroid before you are starting the stimulation protocol in IVF cycle. And I am telling also endocrine co-founders in vitamin D also, because vitamin D receptors and 1-alpha hydroxylase are expressed in endometrium, ovary, and placenta, a possibility reproductive role. And deficiency is highly prevalent in my state, in Odisha. So due to limited sun exposure, lots of causes are there, food habit, all are met, all condition matters. But in our practice, what I am doing, before starting the stimulation, I am giving the 60,000 international units per week for 8 weeks before stimulation to get an optimum vitamin D level. You have to see for all the androgens also profile in the IVF workshop, starting from total testosterone, DHEAS, then 3 androgen excess, and 17 hydroxyprogesterones. Because DHEAS, you know that it is produced almost exclusively from the adrenal zonar reticularis, most adrenal specific androgen marker. So mild to moderate elevated, you know it is elevated in PCOS. When it is a mark elevated, then you can rule out, you have to rule out the adrenal tumor and in some cases non-classical CS. So in testosterone level, that is also, everyone knows this is also included in the Rotterdam criteria pillar on the PCOS, it's a biochemical marker. Then in PCOS hormonal profile, that is you have to see the AMH level, one the important highly elevated, and also you have to collaborate with the AFC level, it is more than 20. And the HOMA-IR investigation or fasting insulin in selective cases, you can go see to know the insulin resistance. And when you are suspecting poor ovarian response, you have to see for the AMH level typically low, and FSH will be high, FC will be very less than 5. And for diminished ovarian reserve, you have to interpret basing upon your AMH level according to your plan, the stimulation protocol. And in diminished ovarian reserve, consider the mild stimulation or antagonist protocol with individualized higher starting dose. Always prefer a high starting dose, and you always combine LH when you are stimulating this group of patients. FSH with LH always work better for poor ovarian reserve, and you get a good number of M2. So hormonal evaluation in endometriosis, we see that AMH level is often reduced. When there is a previous cystectomy also, the AMH level is quite low. So before going for surgery, any endometrioma surgery, always go for AMH level, and followed by surgery, always do a AMH level. And always prefer a long protocol GnRH agonist downregulation like 1 to 3 months before IVF, that improves the outcome of the in advanced diseases. In hypo cases, FSH LH will be low, and it's a good prognostic patient, and normal AMH with low gonadotropin predict the external response, one exogenous gonadotropin are given. And this is a just flowchart. This is a diagram. You can see that how the hormonal monitoring during the ovarian stimulation protocol. This is normally what theoretical perspective I am telling you. But in my practice, what I am doing in the day 2 of the cycle, I am not routinely doing the E2, because the all transvaginal ultrasound are done by me only, because I can see predict how my drugs are responding, how the gonadotropin is responding, and I individually monitor directly, so that I am not going to do the extra E2 for the patient in the whole cycles and also increase the burden to the patient. So in that cases, baseline normally what your FSH LH is normally you simply do a AMH, that's sufficient, and not and that is when you are doing your ultrasound yourself, then no need to go for E2 also. So, but in theoretical prospect, I will tell you the estradiol monitoring for the prediction, like when there is a very high, more than 3500, in that cases, that is risk of OHSS, that you can counseling can be done in a proper way. And in such cases, always favor for a agonist trigger, because in my hospital, in what we are, our protocol is OHSS free clinic. My all cycles are antagonist cycle with a agonist trigger with a freeze all protocol. So that is a zero OHSS. But when in E2 is important, because for the how your drugs is responding or not, like when there is a 150 to 200 per mature follicles at a trigger, it is a common that is benchmark or it is responding. Then daily rising 50 to 100% early stimulation is reassuring. And when it's slow rising, you can consider the increase the dose when we are going for the COH protocol in IVF cycle. This is how this is E2 is helpful. The progesterone monitoring at the trigger, when there is more than 1.5, that's a premature rise may be there, and strongly consider to freeze all and defer the transport to the frozen cycle. If you go for the SCG and GNI agonist trigger, in the decision is that in all cycle, as I told, I go for agonist trigger for all OHSS. There is no risk of OHSS, and in you can prefer the SCG trigger, particularly in the poor ovarian reserve cases. But what I am doing in poor ovarian reserve, I am going for a dual trigger, SCG plus agonist trigger, to get the good number of M2. Then hormonal red flag sign during the IVF cycle, you can see when the E2 is very high, more than 3500, and unexpected very low E2 with a high FSH midterm. Progesterone is more than 1.5 on the trigger day, premature LSH in the antagonist protocol. These are some of the danger signs. You have to red flag sign you have to see when you are monitoring the IVF cycle. In unexplained poor response, these are some of the case scenario you can see. And when there is, I'm giving you an example here, a 32-year-old regular cycle, 2 years of unexplained infertility, first IVF cycle was a standard antagonist protocol. If you see here, the AMH is very low. It is 0.9. And also, you can see day 2, E2 also 92. In such cases, the counseling always matters. When there is an unexpected result, or we are getting less number of eggs, in the good forward counseling, the realistic oocyte yield, consider a high individualized starting dose. You have to increase the dose. The maximum possible dose you can give the gonadotropin for the stimulation protocol. And also, you have to consider and counseling this patient for the oocyte accumulation in this cycle. Then hyper-responsive case scenario, similarly with the PCOS with 26-year-old female in first IVF cycle, the standard agonist cycle, and in PCO patient, teen PCO patient, no need to go for high dose like 300 or something like that. You start with simple 150, and accordingly monitor this patient. And this is and you have to decide the agonist trigger with a freeze-all cycle. On the trigger day also, you have to see when there is a, in this case, you can see 29 years with a normal age of standard antagonist protocol. If you see that the progesterone level is 1.7, in such case, always go for a freeze-all cycle. No need to go for a phase transfer. So what are the common mistakes in the hormonal evaluation? If you see, skipping the universal tests. In some cases, no need, every patient I am telling you, you have to go for a TSH is the must in such cases. Because many cases we have seen that the TSH is not and your stimulation is going on. So this is some of the compounding factor. You have to go for some of the evaluation in such group of patient. Then over relying on the one AMH value without considering the assay of believability or repeated testing with the result of conflicting with the AFC. Then using the SCG trigger in a clearly high risk OHSS patient, the more chances of there is a morbidity to the patient. Along with that, ignoring a singly elevated trigger to progesterone because everything else will look good. So these are some of the points you can highlight and some of the mistakes you can avoid to get a good number of follicles in the IVF cycle. So in the last, I will tell you some of the practical hormonal tips to improve the IVF success. First thing, you have to give basic evaluation, all hormonal evaluation. No need to go for all the tests. What is the basic test that will important for the patient, that will, and according to the cost, we to minimize the cost. Along with you to do the individualized protocol. Always correct the vitamin D deficiency before you are starting the protocol. Decide the trigger in advance and discuss with the patient. And always treat the hyperprolactinemia, the important factor. You have to treat this group of patient. Progesterone assay, that also always matters when in the stimulation. And re-screening after a failed cycle. When there is any fail in the cycle, you can go before planning the endometrium, before blaming the embryo. You have to recheck the other factors also. If that is something you are missing, that group, like some of the hormonal parameter, you have to see. So this is the one slide I am taken from the ISRE, and you can see that for the low responder, you have to start with low responder, normal responder, and high responder patient. The dose determinant mole is all. I always tell that in case of a normal responder, 225 is always good. In a hyper responder cases, you start with 150, and in low responder cases, you can start with the 300 gonadotropin. And always prefer in such cases go for ultrasound monitoring. If it is needed, you are not confident with the ultrasound, or you have someone else is doing your ultrasound, your radiologist is doing your ultrasound. In such cases, you can go for the estradiol level also to correlate what is the ultrasound finding and what is the estradiol level during the monitoring process. And in such cases, I always tell to go for a agonist trigger and combinedly trigger in such cases, double trigger in case of low responder, and never give a SCG trigger, particularly in PCOS patients and hyper-responder cases. And always prefer a phase cycle. Phase also, there is some role of the phase cycle in some cases, the limited role, but in maximum cases, when you compare between the phase and frozen cycle, that is always the frozen cycle you will get a better result. So what is the future? The future, as we are in the now in the AI domain, so AI-based hormonal prediction also matters. That is a multi-parameter response prediction, machine learning model, how we can compare the AMH, AFC, age, and prior cycle data to individualize the starting gonadotropin dose. Then imaging, the Sono ABC is there, the automated, less operated, dependent AFC, that always matters. Then also dynamic trigger timing algorithm also, that you can take the help of AI. Then also integrated risk dashboard, that you can predict the success, and accordingly you can counsel this group of patients. So what is the take-home message for everyone for this session? So evaluate the hormone which are required, not that it's a profile, you can evaluate all the hormones that is which is not required. And secondly, all the gonad, if you compare, many times they ask what is the gonadotropin you are giving, if the recombinant is better, if your urinary is better. But if you see the different studies, everything has a good result and the same result. Antagonist protocol, agonist trigger, and frozen embryo transfer always considered for a OHSS clinic, and low cost IVF always matter. In poor ovarian result, you will always consider for a ovarian rejuvenation, particularly in such cases when you are trying for a no donor concept. So these are my references, and you can get a slide by just scanning this QR code. Then what I have presented, you can go through in the later on also. Thank you all.
Thank you, sir. I request ma'am to please share her remarks.
Thank you, Dr. Shakti. It was very crisp and very complete, elaborate talk on this hormonal assay, because there are so much confusions, which test to do and when to do, how to interpret. So because nowadays everyone is doing our own sonography, so we can reduce the unnecessary hormonal assays, but we have to be wise in doing some hormonal assays. Like if there is a cyst, we need to do E2. If on trigger date, definitely we should do P4 level. So I think you have covered everything, what to do and what need not to do. Thank you so much. Thank you so much.
Thank you, ma'am. Thank you.
Thank you, ma'am. We now move to our last segment, that is the panel discussion. It is my privilege to...
Yeah, Ankita, will you share the CVs of our moderators, Dr. Amandeep and...
Your voice is breaking.
Yeah. So the most important and last session of today's webinar is panel discussion on optimizing IUI. And for that, we are having our moderators from Jammu and Kashmir chapter, Secretary Dr. Amandeep Anand from Jammu Kashmir chapter, and she very I'm very thankful that Dr. Amandeep collaborated for this webinar, and Dr. Amandeep is consultant gynecologist at Jammu Hospital, and she is visiting consultant at Jammu Center for Human Reproduction Care and Cure Hospital. She had so many association with IFAs, MAMS and IMA, IMS, ISAR, and she is rightly General Secretary of Indian Society, Jammu Chapter, Joint Secretary of Menopause Society, Jammu, and Jammu OBGY Society from 2012 to 15, she is gold medalist in OBGY from Srinagar University of Kashmir. So, welcome Dr. Amandi for your panel moderation.
Thank you, ma'am, for such a warm introduction.
Thank you. Thank you for joining and collaborating. So we are having one moderator with Dr. Amandeep, Dr. Manisha Bhagat. And I remember Dr. Manisha very happily joined MP chapter during this UI ISAR when we were not having much
Yes, ma'am.
panels from our chapter. So thank you, Manisha, and welcome to you for this webinar. And she's having so many achievements, Jeevan Jyoti Award in Horizon to Jammu, second prize in Fame Conference, third prize in Infertility Conference, AIMS Delhi, and she's FNB in reproductive medicine, and she had been having so many publications. So over to you, and kindly invite your panelist. Thank you so much. So you can invite your expert, Dr. Gauri, and other panelists.
Ma'am, you can invite Dr.
Yeah, I'm
Dr.
already
Amandeep.
there. Yeah, I'm already there.
Okay.
So do you invite, are you going to invite your panelists?
I would like to invite our panelist, Dr. Ishita Ganguly from Madhya Pradesh,
Hello,
ISAR.
ma'am. May we have the CV, please?
Yeah. Dr. Ishita Ganguly.
Yes, ma'am. Yes, ma'am. I'm here.
Yeah, can I have the CV, please?
We'll share the CV.
Ma'am, CV I've already shared, ma'am, actually.
Yes, ma'am.
Ma'am, the
We have
CV is
it. We
visible.
have it, ma'am. Yes.
Dr. Ishita is an assistant professor, Kaminini Institute of Medical Sciences, from March 25 to 2010. She had been Associate Professor, Kaminini Institute of Medical Sciences in the Department of OB-GYN, Director and Unit Head in Department of Obs-Gynae, Lady Halima Hospital, a trust hospital attached to Al Farouk Unani Medical College. She has work experience from March 2012 to December 14 as consultant GADA Life Test Tube Baby Center, Chill Apollo Hospital, Indore. Welcome, ma'am. Our second panelist is Dr. Archana Maheshwari from Madhya Pradesh. She is Director of Balaji Hospital, Ujjain, Director of Ma Gada Life ART Center, Ujjain. She is Secretary of Ujjain OB-GYN Society. She has done her MBBS from MGM College, Indore, MD from KM Hospital, Mumbai, and FCPS. She has been a gold medalist. She has done diploma in gynae endoscopy by Kiel School and fellowship in minimal access surgery from AMASI and fellowship in infertility from Israel. Her area of interest is IVF and laparoscopy. May I invite our third panelist, Dr. Shruti Gupta. She is Center Head and Infertility Specialist at Imiprimis IVF Infertility Center, Jammu. She is FNB Reproductive Medicine from Rubial Clinic, Pune, DNB NVE Delhi, MD from GMC Srinagar, and MBBS from SKIMS Srinagar. She is trained in gynae endoscopy from Pune, has published many paper and case reports in national and international journals, and has participated in Foxy Usha Quiz Pune round and life member of IFS ISAR, has recently received ISAR Youth Icon Award 2026. Welcome, Dr. Shruti. Now I would like to invite Dr. Sunita Jamwal. She is from J&K ISAR. She has done her fellowship in infertility and reproductive endocrinology from PGI Chandigarh. She is an MRCOG from London, UK. Fellowship in minimal invasive surgery from Amira Healthcare Chandigarh, and she is certified in OBS and Gynae ultrasound from Bilmed Institute of Ultrasound, Gurgaon. She is ex-consultant at Cloud9 Hospital, Chandigarh, and ex-visiting consultant at Medicover Fertility Center, Chandigarh, and also at IVF consultant at KT Multispecialty Hospital. Right now, she is senior IVF consultant and center head at Seeds of Innocence IVF Center, Jammu. She has many publications to her credit and has been awarded first paper prize in IAGE Punjab chapter. Areas of interest are fertility, gynae endoscopy, high-risk pregnancy, genetics. She is lifetime member of Royal College UK, IFS and ISA. Welcome, Dr. Sunita. Now, may I invite Dr. Nihar Ranjan Bhoi? He is Chief Fertility Consultant, Crescenta Fertility, Bhubaneswar. She is a reproductive medicine and advanced laparoscopic surgeon, managing committee member ISAR Odisha chapter, former head clinical research and academics Indra IVF group. He has over a decade of experience in ART and has successfully performed 5,000 plus ART procedures, trained many gynecologists across India and 50 internationally, author of 30 plus peer-reviewed scientific publications, and had been national and international faculty at ISAR, Aspire, and many academic forums. He's passionate about evidence-based fertility care, research, and education. Welcome, sir. Our next panelist is Dr. Narahari Agasti. Has fellowships in MIS, reproductive medicine, cosmetic gynecology, high risk pregnancy, and advanced ultrasound. He is a gold medalist, academician, and advanced gynae surgeon with expertise in MIS, reproductive medicine, high risk ops, and advanced ultrasonography. He has many invited lectures and international academic engagements. Right, he has a core expertise in advanced lapro and hysteroscopy, infertility, advanced ultrasound, and cosmetic gynecology. Member of IAGE, ISAR, SMFM, ISOPAR B, IMS. He had been ONG Professor OB-GYN, KIMS Bhubaneswar, Director Sri Ma Mother and Child Care Hospital, and University Examiner for UG PGDNB. He has done his fellowship in MIS, reproductive medicine, regenerative medicine, cosmetic gynae. He had been a gold medalist in MBBS and MD. He had been founder secretary State Gynae Society, executive member ISAR and IGE, and scientific chair for National ISOPA B 2021. Written over 20 plus book chapters, many invited lectures, national international publications, and has got AICOG CL Javeri Award, ISAR Young Achievers Award, Best Paper Award at IAGE and IFUNB 23, and Seva Ratna Award at 2022. My next panelist is Dr. Mausami Acharya from Odisha, ISAR. She has MD, DNB, FRM, CMC Vellore. She's Chief Consultant, Center of Reproductive Medicine, KIMS Bhubaneswar. She has done fellowship in reproductive medicine from CMC Vellore. Her areas of interest are reproductive medicine, infertility, and adolescent reproductive health. She has 12 indexed publications, including international journals, presented in various state and national conferences, awarded Best Oral Paper in AOGD 2007, and has additional training in laparoscopy under Women Health Initiative and trained in ultrasonography, Randhawa Institute, New Delhi. She is member of ASHRAE, ASRM, ISAR, and FOXY, and JSO PRP. Our next panelist is Dr. Dataram Gawas. He has done his diploma DGO from Goa Medical College, DNB Ops in Gynae Lakshmi Hospital, Kochi, and has been specially trained in gynae minimal access surgery, infertility evaluation and management, high risk ops and gynae ultrasonography, professional memberships of FOXY, IMA, and ISAR. Now our expert is Dr. Ankita Pancholi.
I think expert is Dr. Gauri.
Dr. Gauri.
Dr. Gauri is already introduced. You can start your panel.
I was about to introduce her expert in the last. So she will be the one who will be making final comments. So Dr. Gauri Rupesh Gons, she is Secretary Goa ISAR. She has got super specialty training in IVF and ART at Jaslok Hospital and Research Center with Dr. Firoza Parekh for 2 years, and she is consultant at Dr. Gauri's Clinic, Mapusa, and at Sunshine IVF Center, Mapusa. She is Secretary ISAR Goa chapter. Welcome, ma'am. So over to Dr. Manisha.
Thank you. Ma'am, shall I start the screen share?
Yeah. Yes.
Yeah, please.
Just wait a minute. Ma'am, is it visible?
Yes.
Yeah.
Yes, ma'am.
Okay. So, a very good evening to all. So, we'll be talking about a very important discussion, that is how to optimize IUI results. Am I audible to everybody?
Yes. Yes.
So, as we have already done the introduction, Dr. Amandeep K. Annan and Dr. is with us in the moderating panel, and Dr. Gauri is the expert in the panel. So, let us start with IUI. Why IUI? IUI is a simple procedure. It is first choice for young couples. It is safe and less invasive. That makes it one of the simplest procedure and first procedure to be offered to couples who are young and probably who has done 2 or 3 cycles of ovulation induction. What is the rationale of doing IUI? It is the deposition of good number of highly motile and morphologically normal sperm in the uterus near the fundus at the anticipated time of ovulation. So we'll be talking about the indications, the contraindications, ovarian stimulation which are used. How do we monitor the cycle? What is the time? What should be the time for trigger? And trigger and timing of IUI. How do we collect the semen? What are the preparations available? Whether we do a single or a double insemination, and a word about luteal support. With this, let us start our first question. So my first question, I think I've already shared the.
To Dr. Ishita Ganguly.
Yeah, so to Ishita
Yes, ma'am.
Ganguly.
Yes,
So my
ma'am.
question is, a 24 years old female with primary infertility. She's been married for 4 years. She
Yes.
has a fairly regular cycle.
Yes.
Her AFC is 7 to 8 on each
Yes.
side. She has patent HCG, patient tubes on HCG. HSG, she has taken 3 cycles of clomiphene citrate, and there has been a documented ovulation in all of them. Her husband's Siemens analysis is within normal limit. She has done 3 cycle. Now she wants to know what to do next. So, what do you, as a panelist, want to do? Whether you want to still continue 3 more cycles of OI, or you want to upgrade your treatment, and what does the evidence says?
Madam, I would like to upgrade the treatment because, as you know, she is the. If you look at the duration of marriage, which is pretty long, it's like 4 years she has been married, and she has been taking siphon. So we don't have the sonography, but siphon, if somebody has suggested clomiphene citrate, most likely she must be a patient of PCO, might be most likely, and she has many factors because now it's already 4 years marital life, 3 cycles of ovulation induction. I would like to upgrade with gonadotropins and IUI both, so that at least
Okay.
she has a control stimulation with gonadotropins and going ahead with the IUI, because as the evidence of ASRM and all, they said that if we go for a gonadotropin with IUI, the overall percentage cumulative cycle is somewhere between, a simple ovulation induction is 12 to 14, it goes up to almost 16 to 35%. So looking at the duration of the marriage and the history, and she is fulfilling all the criteria, the less than 30 years age, husband semen analysis is very good, tubes are very good. So I would really like to upgrade with IUI
Okay.
and
So yes.
gonadotropins.
So if you look at NICE guidelines, they don't believe in IUIs. They say you should not routinely offer IUI with mild stimulation or unexplained. But what ASRM says in this practice committee guidelines, it says that after OI, the best initial therapy is 3 to 4 cycles of ovarian stimulation and IUI, and either with CC or letrozole followed by IVF for those couple who are unsuccessful in achieving pregnancy with simple ovarian stimulation. So if you look at one of the score, which is a Honard score, which is helps to calculate the probability of spontaneous conception in within 1 year, it takes 3-4 parameters: the patient's the postcoital test, female age, duration of infertility, previous pregnancies, and referred by gynecologist, a percentage of progressive motile sperm. So what does the score tells you? If the score is more than 30, that means the probability of conceiving within 1 year is very high, and tell the patient to wait for 6 months. But if the score is less than 30%, then probably it is better if you go for with OI with IUI with ovarian stimulation. So this I've already discussed.
If I may add something.
Yes, sure, ma'am.
Hello. Yeah.
Yes,
Just
yes,
that
ma'am.
the
Please.
age is the only. Yeah, she's only 24, although of course married for 4 years, primary infertility, so that suggests low fecundity. But I would have given her letrozole at least before actually jumping on to doing an IUI. I would give her letrozole, maybe add a little bit dose of gonadotropin, and then see. Then there's, of course, after that maybe IUI. This is my take on it, but of course the panel may differ.
So that is what, ma'am. There is a difference of opinions, but that is
Yeah.
what everybody can take a pick, because we can go
Correct.
both ways. So if I look at the indications, it is unexplained infertility, mild or minimum endometriosis, cervical factor, anovulatory infertility, and in male factors, it should be mild semen abnormalities, physical disability, psychosexual, sperm washing in HIV positive man, and donor insemination. So my next question is to Dr. Archana Maheshwari, ma'am. We have a
Hello.
young female which has regular cycles and history of ectopic pregnancy. twice affecting both the tubes, but which has been managed medically. Recent HSG shows bilateral patent tubes. She's been trying to conceive since 2 years but didn't conceive. Now, shall we proceed for IUI? Or is there any other treatment you want to offer?
See, previous bilateral ectopic managed medically by itself is not a contraindication for IUI. But see, HSG is normal and showing patent tube. But we can comments, we have to keep in mind that and ciliary function may be affected because of previous ectopic. So we can consider for IUI, but we have to explain the patient that the chances of recurrent ectopic pregnancy is always there. That is more than in general population. We can go for IUI, and but we have to do serial beta HCG monitoring to see for the ectopic and early TVS and 5 to 6 weeks to rule out ectopic pregnancy.
Ma'am, what does the house says? I don't agree, ma'am. So what does the house say? Somebody
Maybe
else
ask
wants to
Dr.
contribute.
Gauri to have an expert comment on this.
Yes,
Ma'am, what
ma'am.
would
Dr.
you do?
Gauri, what will you do?
See, you all have said the patient is young, so I think age is again in our factor. The HSG shows tubes patent, that is, the patency is established, but we know the function may be affected. So if she's very well convinced and if she is compliant, and then she can come for a follow-up, she would do a beta HCG, she would do a TVS, and then on her own responsibility, if she's willing to go ahead, then yes, IUI again, if she's willing to go ahead. Very well explained that she can still have an ectopic. If not, she doesn't come back for follow-up soon, we may miss it. So yes, again, the house, it's open for discussion.
Ma'am, see,
But I would say
what
we
I
can
believe,
try
yes.
Ma'am,
an
I have
IUI because she's young.
experience.
Yes,
Madam,
I have a, yeah,
I
please
have
go ahead.
I have quite a few patients who managed medically. Means my patient only, and she conceived afterward spontaneously, not the IUI,
Absolutely.
and she did well, ma'am.
Ma'am, what we have seen is that if with one ectopic, the chance of two ectopics is 15%.
That
But
is true.
if there are two ectopics, the chance of third ectopic is
More than
37%.
30%.
Yes.
So that is why it is said that if she has this history, even if the tubes are patent, we should advise
Yeah.
her to undergo IVF.
Yeah.
So
Yes.
with this,
Nice.
let us come to the contraindication. That is severe oats, cervical atresia, stenosis, blocked tubes, dense pelvic adhesions, severe endometriosis, and active genital tract infections. Now, Dr. Amandeep will take the rest
Yeah.
of the two, three questions.
Now we have decided, we have finalized that will be doing IUI. So my next question is to Dr. Shruti Gupta. So what are the prerequisites of doing IUI? What
Okay, ma'am.
we are checking?
Yes, ma'am. Before proceeding for IUI, we should properly select the patient because, as we all know, that success of IUI is on the lower side. So, proper selection of patients is very important. Like we can do IUI in patients, as already discussed, in patients with unexplained infertility, in mild male factor infertility, or patients with cervical factors, or patients with sexual dysfunction, or patient going for the donor inseminations. So proper indication of the patient is very important before proceeding for IUI. Then second most important thing is we should at least one fallopian tube should be open before going for IUI. And third important parameter is that semen analysis report at least show that TMSC count should be more than 5 to 10 million.
Good.
Because that will give us the optimum results. As the TMSC count falls, we have to consult the patient accordingly. That success of IUI will be less with these patients. Uterine cavity should be normal, like there should be no polyps, no fibroids, no adhesions, and endometrium should be healthy. So these all parameters should be taken into account before proceeding for IUI.
Next slide, please. Next slide, Dr. Manisha.
Yes, ma'am. 1 second.
So we see when prerequisites we can talk first. We can previous.
What
slide.
are the minimum? Okay, sorry.
Previous
So
slide.
what are the?
Yeah.
Yes, ma'am.
So what we require is we should ensure that we are having ovulatory cycles, either natural or stimulated. Patent functional tubes, as you have already mentioned, at least one. There should be good ovarian reserve. Female age should preferably be less than 38 to 40 years, as we'll know more in subsequent slides. And day 3 FSH should be less than 10. There should be no uterine factor, and there should be normal or mildly abnormal semen parameters. So now we have decided for IUI. My next question is to Dr. Sunita Jamwal. What are the minimum basic equipment needed for setting an IUI lab? Next slide, please.
Ma'am,
evening,
I've
ma'am.
made the
Good
slide,
evening,
please.
ma'am.
Good evening.
Yeah. Ma'am, am I visible?
Yes, you are audible.
Not visible, but
yes.
Oh.
What are the?
Yes, ma'am.
Can you see the
So,
slide?
yes, ma'am, I'm able to see this slide. Good evening, ma'am. Ma'am, I have started the video, but it's not showing here.
Okay, no problem.
Basically, in IUI lab, we have to see so many things. First is quality assurance. We have to see whether sterility of the equipments, patient safety, as recommended by the ASHRAE, ASRM, and other regulatory bodies. So first coming to the, if I come to the essential equipments to be used in IUI lab, and essential, like first of all, there should be a scrub area, semen collection room, and andrology lab, along with laminar airflow. Basically, that is for the sterile work area for the semen preparation. And then there should be a microscope, and basically that should be a phase contrast microscope for semen analysis. And after preparation of the semen, we have also to see the motility of the like total motile sperm count for that also. Apart from that, we have to have one centrifugation machine for the preparation, whether by the density gradient media method or by swim up method. And one more thing is incubator. We usually require the CO2 incubators, or we can require dry block warmers, which maintain the motile sperm at the optimum temperature, that is 37 degrees. We also need one refrigerator that is for basically media to maintain it at 2 to 8 degrees. And apart from that, we also have consumables, which include small pipettes and conical tubes of 15 and 50 ml for handling the media as well as the semen. So apart from this, IUI catheters and media that can be density gradient, sperm media, and the culture tube should be there. And after this, there can be some of the methods by which we maintain the quality control. For example, infectious, how to control the infection, how to maintain the records, how to maintain the traceability of the patient. And if any time, if any patient with positive viral markers come, how to segregate them from the other samples. And we have to make SOPs for the sample handling and semen preparation and waste disposable as well.
Yeah. See, as per latest ART Act, for a level 1 clinic, we need only 3 equipment: refrigerator, centrifuge, and microscope. But as we all know, these 3 things cannot, with these, we can only not only do IUI. So for optimizing our results, we need all the equipment, as already mentioned by Dr. Sunita Jamwal. And apart from that, we have to have our consent forms handy. Perfect. So my next question is to Dr. Narahari Agasti. We have decided for IUI, so what next? Natural or stimulated cycles? A young couple married for 3 years, unexpected management till now, with mild male factor infertility, were counseled to go for IUI for the first time. So, will you go for natural or stimulated cycles?
Dr. Narahari.
Dr. Narahari Agasti? If not available,
I think he's not
then
joined the group.
Okay, so somebody else can answer the question.
May I ask Dr. Gauri?
Yes, I would definitely do a stimulated cycle for this patient because it's 3 years they have been trying, and there's a mild male factor in fertility also. So I would give a letrozole, add a little bit of gonadotropin, and then take it forward. But definitely not a natural cycle for her.
So, evidence also says same that mild male factor infertility and unexplained, we should go for initially 3 to 4 cycles of ovulation induction at IUI with oral agents. If unsuccessful, then we go for IVF. Next slide, please. Advantages of stimulated cycles are we have number of we have surety of the oocytes available, there is
Correct.
increased chance of fertilization, steroid production, increased chance of implantation, and we can know exact time of ovulation insemination, and also it can correct subtle ovulatory disorders such as luteinized and ruptured follicles. In cases of unstimulated IUI, these we can do unstimulated IUI we can do in the patients where there had been psychosexual problem, like they are unable to have vaginal intercourse, and for sperm washing and IUI in HIV positive men and donor semen IUI. Though in these also we prefer stimulated cycles. So over to Dr. Manisha now.
Okay. So my next question is to Dr. Nihar. Hello, Dr. Nihar.
Hi.
So,
Hi, good evening. Yeah.
good evening. So we have a long association, Dr. Nihar and me. Sir used to be our course coordinator also in the IVF. So the question is, we
Yeah.
have a 27 years old female. She's been married since 4 years. Her BMI is 29. She has delayed cycle. Her day 3 FSH is 5. Her LH is 7. On HSG, she has bilateral patent tubes. Her semen analysis is normal. For her husband, she has attempted pregnancy with 2 cycles of clomiphene citrate 100 milligram for 5 days, and then another 2 cycles of 150 milligram of clomiphene citrate without any growth of follicles. Her both ovaries are polycystic with volume of around 13 cc. How do you plan the further stimulation in this patient A? And B, what are the ovarian stimulation protocols you use in IUI patient? So please first tell your further plan in this patient.
So, from history and the findings, it is looking clear that it is a PCO case. So, for that, to plan further stimulation, we have to optimize the BMI, optimize the weight first. Lifestyle modification, weight optimization, that should be the first criteria. And considering the 2 cycle failed with CC 100 and another 2 failed with CC 150, it is designated, you can be stamped it as CC resistant. So letrozole becomes a better choice in this case. You can go for letrozole, but not before optimizing the weight. And importantly, what I practice in case of PCO, I usually give some insulin sensitizers for maybe 2 months, and along with that weight optimization. And I used to give OCPs for at least 2 months so that the baseline LAS level goes down and that follicles respond better. So that is my protocol that I follow, and that gives me much better results.
What does the expert says, ma'am?
I would concur with Dr. Nihar about the lifestyle modification. I would have put on her metformin because she's overweight, and then yes, switch to letrozole. Now, in case again, if she doesn't respond to letrozole 2.5, I would increase it to 5 milligram and then maybe 7.5, and then see see her response. Because I think only 2 cycles have been tried with clomiphene, and she's clearly clomiphene resistant.
Madam, but I would say that the clomiphene has not been. Ma'am, shall I?
Yeah, please,
sure,
please,
Ma'am,
doctor, go ahead.
Ma'am, actually, what I've seen that letrozole, the mode of work in clomiphene citrate, the basic point is that it is the insulin resistant and the LH is raised. So here the molecule which actually works is the only clomiphene citrate. But in this case, the dose is not sufficient. So I would even that as per the recommendation, there are two things. One, we can hike the dose. We can make it up to 250. And secondly, we can give an extended therapy that is for 10 days sometimes. It needs to be given. It has really good results. So I think clomiphene citrate remains the drug of choice in this particular case. Like we can ideally, the patient is. It is very simple to say that lifestyle modification, but it is very difficult for the patient to be that long coming to you and going for it. So I think a better option is that increase the dose and increase the duration. The extended duration, extended therapy for clomiphene citrate is there mentioned in the literature and the guidelines well. That really works well. And secondly, what I've seen that adding metformin is something that glucose monitoring is important, especially with the regular monitoring. If you see that it's always many a times clomiphene citrate, even the PCO people have a very normal sugar level. It means adding metformin may or may not benefit. So here the ideal thing will be increasing the dose and giving it for a longer duration. That really works.
And what about
extended
letrozole?
Letrozole is something I have hardly seen working in a resistant. See, we have letrozole is a drug of choice for stimulation, but in PCO we cannot give letrozole because it doesn't work. It is the modus operandi. If you see, it is an aromatase inhibitor, and here we need in PCO the pathology is the LH rise, which is not letting your follicles grow, and we need to break that. So the clomiphene citrate comes into the picture because it works in the hypothalamus pituitary axis. So I don't see, I'm not fond of giving letrozole. My preference is going even up to, because I have been practicing and I see very good results when we have given it for a very longer duration. Sometimes I have seen that I have given clomiphene citrate for 15 days with a very high dose and people have given a very, very positive result.
So does the
Especially
house
in
agree or the house disagree with whatever doctor is saying?
I don't
No,
agree,
it's
sorry.
I don't agree, ma'am.
I don't agree,
I know, because
definitely.
we are also
It is
using
even
letrozole for a very long
Exactly.
time now.
Most of the guidelines even recommend that letrozole
Yeah,
is the first
letrozole
line
only.
drug for PCOS
Yes,
And
patients.
doctor, what about the endometrium? What about the
Exactly.
endometrium when
that
you're
is
At
giving
such high
so?
dose,
if you give
high
clomid,
dose for long
Endometrium
duration.
Madam,
And what about
endometrium is
optical
always good. It's
toxicity?
always good.
Please, one at
No,
a
ma'am,
time.
and
Endometrium is
clomiphene has a very
sir.
long half-life. It will retain in the circulation for a long period of time. It will not
Yes.
wash
It
off.
doesn't have any
It will
side
not be
effect. If
washed
you
off.
look at, I've been practicing for more than 15 years. I've never seen any side effects. Endometrium grows very well once it reaches a dominant
Madam,
follicle.
I
The
have seen
question,
an OHSS with
endometrium,
50 milligram of CC in PCOS. So, I
madam,
have
I've
seen
never ever seen OHSS.
50
OHSS is
milligram, madam,
something that
50 milligram,
rarest of rare
not even
thing.
100. No,
Madam,
but
it is
that
like
I agree.
it is something that 1 in 100. But
I agree.
you are
It is
meeting
very less.
patient
But
every
then,
month.
but
Clomiphene
we don't
citrate,
use
the kind of
CC.
dose you're giving.
Ma'am, we have stopped using
150
CC long
milligram.
back. Long
yeah,
back we
even
stopped.
I have.
Yes.
I
Yes,
don't
ma'am,
think,
please go
ma'am.
ahead.
I still feel that PCO, this is a very good molecule, wherein ovulation is almost 90 to 95% when we are given it for extended period. And even the guidelines, ASLM guideline, NICE guideline, even have accepted the prolonged treatment that if you are not willing
Madam,
to
if we
increase
look
the
at
dose, you go for
guidelines, then the first line
guidelines, you
of
can go
choice
for
is
extended.
letrozole.
Exactly.
No,
But
when if
ma'am,
we look
you
at the
have your own
guidelines.
practical experience, how much letrozole works
So,
and how
madam,
much chloroquine works,
so what
because
I
the
believe,
mechanism of action is what important. Why
no, what I believe is
PCO is not
letrozole is
ovulating? Because
no
LH is raised.
DOC.
It
No,
has to
I
work in
agree.
hypothalamus pituitary
No,
axis.
it is
May I
not like
request
that, madam. What is if?
moderators?
Yes, ma'am. Let
Ma'am,
us
just
just one
We
sec.
are
Yeah,
having
yeah.
only
Yeah,
half,
yeah. So,
like
okay.
20
ठीक है, ma'am.
minutes more.
ठीक है, ma'am. Let's go to the regime. Let us go
okay.
for stimulation. Sir, this is stimulation other than this, what we can offer?
We can see with letrozole, maybe the step ladder means step up doses you
Protocol.
can try. Maybe extended dose letrozole also you can try. If it doesn't work, you can go for gonadotropins. And
Okay, so for
gonadotropin
gonadotropin,
typically step up protocol. It is never
so you
step
can go
down
for a.
protocol. It's always step up.
Okay, so you can take a chronic low dose step up, step down, or you can start with 50 units of 50 units of gonadotropins and increase it 25 or 50. So these are the protocols. What if somebody else is using something else? How do you give your gonadotropins?
Never prefer a step down protocol. You go for a step up. That is more preferred in PCO.
But then
Yes,
mostly
it
if
is
you give
always.
gonadotropins, you
For
need a very,
IUI at least.
with the resistant one, the gonadotropins, you need to keep on hike the dose and you reach a point where all the follicles will grow. And then again, either you have to counsel the patient that we are cancelling the cycle and go for IVF. Then patient says
So
that,
that
how
is
we are
why,
not planning for IVF.
yeah. So that is why you need to start with very low dose. And you can
Yeah.
start with as low as 50 to 37.5 units every day and increase it slowly after 7 days. And you can either increase it to 25 or 50. So my next
But
question.
getting a
Please.
monofollicular development is very difficult in this.
Yeah, because there is a lot of problem. You have gonadotropin threshold, and once either they will not grow or
Yes.
suddenly they'll blow.
Yeah.
So that is the
They
problem
blow
we
up.
face.
Yeah.
So my next question is to Dr. Mosmi. We have a 32 years old female on she's on clomiphene citrate, and on 11th day of our follicle monitoring, there are two dominant follicles. One is 18 and one is 19, one on each side. When we did the Doppler on the perifollicle velocity is 1/4 of the follicle circumference and ET is 7 millimeter. Her PSV is 10 cc per second and perifollicle RI is 0.3. Endometrial RI is 0.4, uterine PI is 3.1. Would you proceed with trigger? And what is the criteria of trigger in IUI patients?
So basically, trigger is a very important factor in cases of IUI because it improves the pregnancy rates. So in a only CC stimulated cycle, the follicular dominance should be at least we should wait up to 22 millimeter. And I think at this point of time, I will wait for some time because our perifollicular vascularity is also which again tells around the follicular maturity is around 1/4. It should be at least 75%. The ET should be at least 8 millimeter and triple line appearance, and the peak systolic velocity again should be greater than 15. And I think these are some of the Doppler parameters which should be considered before for a pregnancy because IUI has a less chance of pregnancy. And the uterine artery also PI index should be at least less than 3. So routine practice, this Doppler studies are routinely done. In my clinical practice, like for only CC cycle, I wait for a little longer time for a trigger. For a gonadotropin and CC cycle, we can trigger at 18 to 19 millimeter. But if a patient is having recurrent failures and recurrent IUI failures, then this Doppler study to assess the endometrial receptivity, assess the follicular maturity, improves the result to some extent.
Excellent answer. So with
Perfect.
CC and letrozole, we can wait till 20-22 millimeter because with each millimeter of endometrial thickness, with each follicle growth, the optimum ET increases by 0.5 mm. So if I wait from 20 to 22, probably it will increase from 7 to 8.5. But if it is gonadotrophins, we can give the trigger at 18 millimeter also. And if we look at the pre-optimal HCG follicle parameters, the optimal sizing, as we have already discussed, the vascularity should cover at least 3/4 of the follicle circumference. The perifollicle RI should be less than 0.5. The PSV should be more than 10 centimeter per second. The follicle volume should be more than 3 to 8 cc. VI should be more than 6. FI should be more than 35. If I look at the pre-HCG endometrial parameters, triple line endometrium, preferably 8 millimeter. A grade A by B endometrium, vascularity should be in the zone 3/4, and RI should be less than 0.6, and uterine PI should be less than 3.2, as rightly said by the doctor. So with
Perfect.
this, perfect. So let's come to our next question. Ma'am, do you want to add something?
No, doctor, it's
Okay.
perfect. Very well
Okay.
answered.
Okay. So my next question is to Dr. Dattaram Gawas. The first thing is, what is the ideal trigger? And what time do you give? 24 hours, 36 hours, 40 hours? And after what time do you give do your IUIs? And does it vary in stimulated and natural cycle IUIs? And Dr. Dattaram?
Dr. Dattaram is
Sorry, you're mute.
Hello, can you hear me?
Yes, we can hear you, sir.
Yeah, so the most standard timing for IUI taken is at 36 to 40 hours. So the optimal timing for IUI for natural cycles we are set for after 24 hours of the LSS. But the USP trigger with SCG, we do it after 36 to 40 hours of the trigger.
Okay. So does the house agrees, and if somebody is doing it as something different? So I believe HCG we can give one injection and do can IUI after 24 to 40 hours. In cases of natural cycle, it should be performed one day after the LH rise. And if you look at ASRM 2020, it says that it is recommended that single IUI should be performed between 0 to 36 hours relative to HCG injection in ovarian stimulation with IUI treatment. You can take HCG injection, you can take recombinant, or you can use normal urinary injections. It does not make any difference. IUI can be done anything between 22 to 24 to 48 hours. This is what Cochrane says in its review on triggers. So my next question is to Dr. Ankita. What do you prefer in your practice, single IUI or double IUI? And what does the evidence says? What does you do and what does the evidence says? Dr. Ankita. Dr. Ankita? Is Dr. Ankita there?
Hello. Our expert, Dr. Gauri, can answer if she's not available.
Yeah.
Yeah. So the evidence say that single IUI time perfectly is more than enough. Okay, but in certain situations, I would do a double IUI. Example, especially in donor cycles, when we have ampule wherein there are two vials of the same donor given, and when we know that there are two follicles, I would call the patient 24 hours later after the trigger, and then call her once again the next day. These are the very few cases wherein I do double IUI. Otherwise, I stick to a single IUI, well-timed IUI.
Okay. Perfectly answered, ma'am. So, what method of semen preparation do you use and why? Dr. Nihar.
If it is unexplained infertility, normojuspermia, then swim up is enough. All other cases may be oligoastheno, terato, or high density. You can go for double density, density gradient preparations that we practice.
So there are three types of washing: simple dilution, swim up, and density gradient. Generally, with normal samples, we prefer swim up. There is little lower recovery of sperm, and it depends upon the ability of sperm to swim up. Density gradient is generally if the sample is very abnormal, the morphologically sperms are not good, and we get greater recovery of motile sperm based on their density. So the sperm preparation, why is there is a need? It decreases it eliminates anti-sperm antibodies. It removes decapacitation factors and prostaglandins. It removes non-motile dead sperms, and there is collection of good quality sperm. And if you look at the evidence, if you look at the Cochrane, it says that you can use any preparation, whether it is swim up, density gradient, wash. No, not one is above the other, but as we are doing it, what we feel generally, density gradient is better when the sample is not very good. So what does the house says? Ma'am, expert, do you want to add something?
So again, if the sample is very viscous, swim up is not possible. In a viscous sample. So I asked
yes,
the
ma'am.
house, like, what do you all do when the sample is very viscous? Normally we add the sperm wash media itself.
Yeah. Then we pipetting with
Correct.
pipette, we try
Frequent
to
pipetting, but sperm wash media works very well.
very well. Yes, ma'am. So my next question is to Dr. Ishita Ganguly. What is the time interval between sperm collection and semen processing? And what should be the time interval between semen processing and insemination? What is the time interval?
Usually for liquefaction, we give 15 to 20 minutes as a norm. But sometimes we find that it can be a delayed liquefaction. So in case of delayed liquefaction, I wait for some more time also. Or we have discussed pipetting or adding media, something like that. If even after 40 minutes I find that this is not happening, then go for pipetting and this thing, and then going for semen preparation with density gradient or both swim up technique.
So, madam, if somebody is coming from house and he wants to get the sample, what are the instructions you give it to that patient?
Madam, if somebody wants to get the sample collected at home, your question is if somebody is willing to get it.
Yes,
ma'am.
he doesn't
If the
want to do a
somebody
lab collection.
Yes, in that case, ma'am, we take a consent from the patient and we get it signed that the sample has been brought from the home. And even when we send the record, we keep the record with us signed by the patient, both the husband and wife, that the sample has been collected at home by choice.
Okay,
That
so ma'am,
consent is important.
Yeah. So what I wanted to ask
Because
is
tomorrow
the sample should be delivered within 1 hour of the collection.
1 hour.
And you need to
it
tell
should
the
be
patient to keep it
in the pocket.
Yeah.
In the
Pocket
in
of
the
his
pocket.
trouser.
Yeah.
Yeah.
1 hour is also, yes, ma'am. It should be, I prefer less than 40 minutes at least. But the consent for
But
the
1
legal
hour is
purpose
also
of
okay.
consent is important. Yes. 1 hour is okay, but I think 30 to 40 minutes should be fine, and keeping in the pocket. But I'm more worried about even the legal aspect, because the patient is
which is
bringing
you
from home.
correct, which you are very correct,
Yes.
and this is very
Consent is
very I
important.
think your consent is important. So ideally semen collection and preparation should not exceed 60 minutes. Ideal is within 30 minutes, and insemination it should be
90
between 30
minutes.
within 30
Total
to
is
60 minutes preferably.
Yes, collection, preparation, and the insemination. The total duration
90
given
minutes.
is
90 minutes. Yes.
90 minutes. Yes.
Yeah. So my next question is to Dr. Shruti Gupta. Dr. Shruti, what is TMSC, and is there any lower limit of semen sample where you do not like to do an IUI?
Ma'am, basically TMSC is total motile sperm count. whenever we wash the sample, post-wash, we have to calculate first the TMSC. TMSC is like we have to calculate the volume of the semen, multiply by the sperm concentration, and then multiply by sperm motility. Like if and motility should be written as in decimals. Like if its motility is 40%, it is written as 0.4 0.4. Yes, and then we will calculate the TMSC. Whenever the TMSC is more than 10 million, 10 to 15 million, that is a good IUI sample, and we should explain that the success of IUI will be more. But between TMSC of 5 to 10 million, we can still go ahead with the IUI, but we have to explain to the patient. Below 5 TMSC, we should not go for the IUI.
Okay, so if you look at,
Prognosis will be
yes,
less.
very good, very good. We need
Okay.
to tell the prognosis. This is what I believe. But if you look
Yes.
at the pre-wash total motile sperm count, it should be around 5 to 10 million. Motility should be more than 30.
30.
And post-wash morphology should be more than 4%.
4%.
So what we have, patient has, people have seen that with minimum post-wash count at as 1 million, people have seen pregnancies.
Pregnancies.
Yes, but what I believe, ki if the TMSC is less than 5, then the chances of pregnancy decreases. So, but we cannot tell somebody that you cannot do IUI. So, what does the evidence says? Evidence says that it is not possible to define the clear lower limits of pre or post wash semen parameters below which IUI should not be withheld. So, what I believe is I counsel my patient and let them take a call. I tell them what is the probability of getting pregnant with this semen count. And what does the expert says?
Absolutely wrong, doctor. You're bang right. Because finally the patient has to take a call.
Exactly.
So it is absolutely correct what you said. Yeah.
Okay. So how useful is abstinence before IUI? Dr. Archana Maheshwari, ma'am.
Yeah, abstinence before IUI is very important because it affects sperm count, motility, and DNA quality also. So it depends on the semen parameters also. Most of the IUI usually we give 2 to 3 days abstinence, which balance between the motility quality and DNA quality. But in case of estenoteratozoospermia, when DNA fragmentation is more and semen quality is poor, in that case, we give 24 to 48 hours abstinence. It will improve the outcome.
Okay, so great. So 2 to 7 days abstinence before IUI is fine. Shorter period of abstinence increases the pregnancy rate. And in cases, if the sample is not very good, we can decrease the abstinence. The
Abstinence
rationale
period.
is to obtain good quality and quantity sperm. If we increase the abstinence, there is increase in ROS and decrease and more oxidative stress. And that is why we tell the patient not to give too much abstinence and probably give it anything between 2 to 3 days of abstinence is good enough. Now, my next question is to Dr. Sunita. Dr. Sunita, when to cancel an IUI cycle? And at what is your parameter and what does the guideline says? At what time do you cancel your cycle? I know it is very difficult because you have stimulated the patient, everything is ready, and suddenly you tell the patient that you cannot go ahead. So, how do you counsel and what is the criteria for cancellation?
Yes, ma'am. Basically, we have to see many aspects like what is the age of the patient, what treatment she has received earlier, and what you have counseled before starting the IUI. Though the most common reason here is the excessive follicular response, like greater than or equal to 3 follicles, which are like 16, above 16 of size, or in the ultrasound, if we are seeing multiple intermediate follicles greater than or equal to 5, then we can cancel the cycle. And sometimes if the patient has premature ovulation and that window is gone like 12 to 16 hours post rupture, we can assume we can do that. Then also we can cancel the cycle, though it's not a total contraindication. And sometimes when endometrial thickness is less, pattern is not good, we can't cancel, but we can explain the patient that the probability of pregnancy is less. And also, if the total motile sperm count is less than like 1 lakh, then it's not an absolute indication, indication for the cancelling, but definitely minimum that is required is 1 lakh.
Okay. So I was basically looking at the follicle. If there are too many follicles, if it is more than 2 follicles of 15 millimeter or larger, probably we want to withhold giving HCG trigger. And if the follicle is more than 5, on day 6, 7, when we can see more than 5, 6, 7 follicles of like 11, 12 millimeter, probably we'll like not to go ahead. With a count less than 1 million, yes, we can advise. But that is something which the decision we cannot take. But this is something which is good for the patient. So probably we can tell them that probably we cannot go ahead. And I know we have a lot of patients who become angry with us also when we are counseling that we are cancelling the whole IUI. But we have to see the safety of the patient first. Ma'am, do you want to add something?
No, I wanted to ask Dr. Sunita. She mentioned about some E2 and some 14, 16 millimeter. I didn't get that point, doctor. Can you repeat?
Dr.
Actually,
Sunita?
I said about the follicle size, like if it is 16 to 18 greater than 2 in number.
More than 2 follicles. That's what you
More
meant.
than 2 follicle is number. And then I
Okay.
was talking about the in-between scan that we do for intermediate follicles. If that is more than 5, intermediate is usually greater than 10 to 12
Okay.
Yes.
So one more question to the house. Once the IUI is cancelled, they ask the patients usually ask, doctor, can we have normal relations? Then what do we tell them?
Ma'am, I tell them. So I had a patient something like this. She had three follicles of six follicles of more than 12 centimeter on both the sides. I cancelled the IUI. I called her after 6 days and I tell her not to keep relation. But ma'am, she was PCOS. On 14th day, she had 6, 7 follicles of 14, 16 mm. I aspirated them and I told her specifically not to keep relations.
Okay.
And what she went ahead, she had relation with her husband and she came after 15 days. Ma'am, my menses are not coming. I did her UPT and she was pregnant. So what I have realized, even if you counsel, they follow whatever they want to follow.
That is true. That is true. That is true.
So that is one thing which I have seen with the patients. So with this, let us take our next question. The semen is processed and sample is prepared. Patient is taken for IUI. While doing IUI, you had difficulty while negotiated the cervical canal. This is a very practical thing which all of us probably has faced when we are, especially when we are in our early practice, where obviously we are not very good with the difficult IUIs and difficult ETs. So how do you go about it? And I don't think so, Madam Doctor Dr. Nagahari Narahari is in the panel. So I would really like the expert to answer the question.
Difficult question, difficult situation. Difficult situation.
This is what we face, madam.
Yeah, definitely. I use normally an ultrasound while doing IUI, so that really helps me. That is one thing. I have the advantage. So I would one tip I would say, never push the catheter, never force the catheter. Okay, try to put it gently as the catheter curves towards the canal. Of course, if you don't have the machine, then it's a bit difficult. But with the machine, with the assistant helping you, you will have to try to traverse. The other thing sometimes I've tried is using a hard catheter, a firm catheter with a stillet. Not easily available, but you can keep it handy, especially if you don't have a machine, that really comes useful. Okay. And I think even if the patient has had history of HSG being difficult, that is one factor that I would normally see. If the patient gives history, HSG was very difficult, then we know there is some problem with the canal, some tortuosity, something is wrong with the cervix. But I think for me, ultrasound machine is a blessing, and I use a machine even for my IUI. So
yes, so very true, ma'am. And ultrasound is a blessing.
Yeah.
So, what are the reasons for difficult insemination? Probably an acutely anteverted, acutely retroverted uterus. There's a steno cervix. There's an abnormal cervical canal, or probably an apprehensive patient. That is also very true.
Correct.
So, what we can do is if it is an acutely anteverted uterus, I would say that you tell the patient not to fully empty his bladder. This is what I tell all my patients before coming onto the table. That you keep your bladder partially full, then apply the gentle traction on the anterior lip of the cervix. Insemination, obviously, ma'am, as you have correctly said, if you do it under ultrasound guidance, probably you will not face the problem. You need to counsel the patient, and the best, if nothing works, you take a hard catheter and do an IUI. So it doesn't make difference whether you are doing it ultrasound or clinical touch. But the only I would say a better part is because we are very much well versed with using ultrasounds, so we find it easy. And otherwise, the evidence doesn't say anything. If you do IUI with ultrasound guidance, it will get good pregnancies. With catheters, you can use soft or firm. It does not make a difference, especially in IUIs. So my next question.
So now my next question is to Dr. Mosmi Acharya. Now we have done IUI. What about luteal support? Do you give your luteal support for all patients? Yes or no? And which is better, an oral, vaginal, or injection, until how long? Dr. Mosmi.
Ma'am, practically speaking, we normally I give luteal support to all my patients. But if I do theoretically, then if I'm doing a CC cycle, then the luteal support is not required. If I'm doing a gonadotropin cycle, then a luteal support is required. All oral vaginal, which is patient is compliances matter. Injectable, I normally is not required. All are equally beneficial, and around 2 weeks of luteal support is required for the patients post IU.
Okay, next slide. See, evidence says that progesterone luteal phase support is beneficial to patients undergoing OI with gonadotrophins in IUI cycle, but all of us are practically giving to all the patients, and luteal support up to 8 to 10 weeks is mandatory in patients with gonadotrophin cycles. So, next. My next question is to Dr. Dataram Gavas. Is bed rest recommended after IUI, and if yes, for how long? And what does the evidence says about it?
Ma'am,
So
I think,
usually,
sorry, sir.
Dr. Dataram?
so
Dr. Dataram, yes,
so
sir.
yeah. So after IUI, usually the rest is for 10 to 15 minutes. That is what the
Yes.
evidence says. After that, usually bed rest is not that much recommended.
Yes. 10 to 15 minutes is enough. We have covered this. So 10 minutes rest after IUI has a positive effect in the pregnancy rate, so it should be mandatory, adopted in standard practice. So ASHRAE has also concluded that immobilization after IUI has no positive effect on pregnancy rate, and there is no reason why patients should stay immobilized after treatment. So my next question is to Dr. Ankita Pancholi. She's here. 30 years female, married for 3 years, has undergone 3 cycles of IUI plus ovulation stimulation without any result. Tubes are patent on HSG, good ovarian reserve, regular cycles. Would you still continue with another cycle of IUI or go for IVF? So when would you say no more IUI? Where to stop? Dr. Ankita?
Manisha, Ankita is coordinating. She is not in panel. I think that's
Yes,
why she's not aware.
I would like our
Okay.
expert to answer this question, because this question is also.
If her ovarian reserve is good at the age of 30, and if I feel I've seen her previous ovulation studies and I can do better stimulation, maybe, then I will try doing one more IUI or one more, because if her ovarian reserve is good. If not, if she has a poor ovarian reserve, if previous IUI were well stimulated and yet the patient didn't conceive, I would counsel her for an IVF. The evidence, yes, ambiguous, 3 to 4 cycles of good IUI, but because beyond 3 cycles, we know IUI usually doesn't give more benefit. That is what I would say.
So evidence also says that more than 90% of total live birth rate from IUI is achieved during first 2 cycles. So 3 to 4 is enough. At least 3 consecutive IUI cycles should be performed. It's a moderate grade evidence.
Madam, but in this case, we need to keep in mind this is a donor cycle, and looking into
Then
the
also,
cycle is pretty expensive. It is
ma'am,
not
even if it is a
yeah,
donor
so
cycle,
keeping in
4
mind this, I would,
cycles, yeah, 4 cycles are more than enough.
madam, but looking in mind that, madam, 4 cycles in the sense, but already she has taken 3 cycles. I'm looking into the cost factor as well. Since it is donor, and nowadays we are taking all from the bank, so it makes it a very expensive cycle as well. So that factor should also be considered.
Yeah, but then also,
I feel
doctor,
that way.
4 cycle is more. If she has
Taken
already
three
taken
cycles,
3, so we can do one more.
3 cycles.
We can do one more, but
Yeah,
I
but
don't
then
think.
added cost is there.
Yeah, added
Cost
cost is
factor is
certainly there.
pretty
IUI
expensive. Donor is
samples are also
expensive.
very expensive.
Had it been a routine, IUI, I would have said going for 4 cycle is okay, because husband sample is there. But since we are taking a donor here, so it
Yes,
makes
so
it very
that is a
expensive.
okay.
So
You
that
want
should
to
be our
say that you
factor
should not
again.
do more. Okay,
Yeah.
okay. You want to
Yeah,
say not to do
already
more.
we have tried
Okay.
thrice. That
Yeah.
cost
Yes,
is
that
already
is
being
true.
added to the,
That is there.
yeah.
Yes, she has
Point
already
Just
done.
because
well
it is donor, that's
Yes,
all.
yes,
Because the
yes,
question is
that's right.
specific the
Well,
donor IUI.
Yes, yes. Donor IVF, that is what I said. Yes, very
Yeah.
rightly said. So my last question is to Dr. Nihar. A 41 years old female wishes to become pregnant using donor insemination. Her general medical history is unremarkable. She gets her regular cycles every 26-28 days. She had a history of MTP 22 years back. Her AFC is 4. Her AMH is 1. So what do you what do you want to do for this patient? Whether you want to go for IVF, IUI, and how do you want to proceed? And when do you
IVF.
refer your patients for IVF, if at all?
IVF only. If at
IVF
all 4
only.
AFC are there and AMH is 1, there is no question going for IUI. At least you can try to retrieve those and plan for PGT, and you
Okay,
can
yes,
plan a transfer.
Yes, very rightly said. For older age, superior pregnancy rates with fewer cycles to immediate IVF has been seen, especially in the age groups of 38 to 40 years. So what evidence says, women with FSH of 10 to 15 MIU and E2 of more than 40 on day through were unlikely to achieve live birth rate with COH IUI. So when to refer? What we believe is there is increased duration of infertility more than 4 years, increased female age of more than 38, 39. There is associated severe male factor infertility. She has grade 3, grade 4 endometriosis. And probably after 3 to 4 IUI cycle, you can think about now referring the patient to IVF. What does the house says?
Absolutely. Absolutely. Because I'll counsel the patient ki every one menstrual cycle is precious. Each one, every month she's delaying, she's losing the oocyte quality for quantity and quality, of course. So rush into IVF, definitely. That is what I would say.
Okay. So with this, let us conclude. IUI should be the first line of option in cases of unexplained mild male factor and donor insemination. It is simple, safe, non-invasive, and cost-effective. But there should be careful selection of patient depending probably on female age, TMSC, duration of infertility. Failure of 3 to 4 cycles of stimulated IUI in unexplained or mild male infertility, please think about IVF. Stimulated IUI with oral ovalogens are better with respect to multiple pregnancies and live birth rates. Single insemination is better and luteal support is not required in CC cycles. Thank you for your patient hearing. I thank my panelists for such a lovely discussion, and I thank moderators and I thank the chair for giving us this opportunity of doing this panel.
Thank you so much, everyone.
Yeah. Thank you.
Thank you
so much, ma'am.
everyone.
Thank you so much. Thank you.
Thank you,
everyone.
everyone.
So it
Thank
was
you.
great panel and all the panelists were there today because most of the time so many absenteeism. So it
Yes.
was great discussion from all over Jammu, Kashmir, Goa, Odisha, MP. So it was very good collaboration with all of you and wish to meet you everyone in some physical meeting. And at the last, I would like to request you that kindly vote in support our own Dr. Archana Basir ma'am. She is a really very, very apt candidate for Foxy President. And my sincere thanks to all the chapter chair and secretaries, Dr. Rajat sir, Dr. Madhulika, Dr. Milin sir, Dr. Gauri, Amandeep, Dr. Anil sir, and all the faculties, Dr. Call Madam, Dr. Sunil sir, everyone for joining. All the panelists were superb, and it's really very, very good discussion on IUI. Thank you so much, and my sincere thanks to our MOC, Dr. Ankita, for making it so flawless, and the Farmed people for giving us technical support. It was really a very nice platform. There was not a single technical hitch. So thank you so much. Wish to meet you all sometime. Thank
Sure,
you so
ma'am.
much.
Thank you,
Thank you,
ma'am.
ma'am. Thank you. Thank you.
Bye-bye.
Thank you.
Thank you,
Bye-bye.
ma'am.
Dr. Mandeep. Thank you.
We may leave now, yeah?